ophthalmology initiatives. So we shall, without any ado, go on to our first speaker. Our first speaker is Dr. Tushar Grover, who is the director and consultant of Vision Eye Center and a consultant at Gangaram Hospital, New Delhi, a cataract, cornea, and refractive surgeon with a very good presence. Let's watch his challenging experience. Could you share your screen, Dr. Tushar?
Yes, ma'am. Is my screen visible?
Yeah.
Yes.
Okay. First of all, I'd like to thank ARC, Dr. Chitra ma'am, Dr. Harshal sir for the opportunity. Thank you so much for having me here. Thank you. So I'll be talking about issues that happen with femtosecond capsulotomy, and one of the common situations where this happens is when you have a small pupil. So something that usually works well is by cheating the machine a little bit, and we manually adjust the diameter of the pupil that the machine has detected, and we increase it manually, and that usually works well. So we usually get an adequate sized rhexis which is well within the pupil diameter on most instances. But sometimes this can go wrong, such as in this case, where once we took up the patient for surgery, we noticed that there was some pigment dispersion, which is why we stained this particular patient. And when you look at this case, it's quite evident that a part of the capsulotomy by the femtosecond laser has been done over the iris. So the energy has been delivered onto the iris, and quite evidently, there is an area of uncut capsulotomy. So in these situations, this can be quite tricky because you have that uncut area, and it's possible that this can go peripherally. So it's important to be extremely gentle, extremely careful, and do a manual capsulorhexis here in this area. If we had micro forceps, that could have probably been made things a little easier, but with the regular capsulorhexis forceps, doing it very slowly and gently, we were able to satisfactorily complete the manual capsulorhexis here, and following that we were able to take the capsule out, and this particular case was uneventful after that. Another situation where you can have these issues with capsulotomy is when you have white mature cataract. So we do usually increase the energy settings and increase the depth of the capsulotomy as well in white mature cataracts, because you can possibly have tags left behind, because there is some milky cortex that is released at the time of capsulotomy, and it's quite common to have some incomplete capsule tags left behind in white mature cataract. So that's why it's important to stain white mature cataract cases even in femtocapsulotomy, because you want to be a little careful. And sometimes you have what looks like a complete rhexis, but if you look carefully here, there is that uncut area of about 2 clock hours. And if we were not careful, this could have gone peripherally. But sometimes in cases like this, where we have about a 6 clock hours of uncut capsulotomy, and we did manage to get a manual capsulorhexis, but as soon as we went in and we did the nucleus segmentation, we realized that the anterior capsule has gone posteriorly, and there is a posterior capsular tear which is quite large with drop of the contents. So it's important to be very careful with these first few steps in femtosecond laser, as we saw in these two cases. And it's important to remove the anterior capsule as if we were doing a manual capsulorhexis, so that in case there are any incomplete tags, we end up getting still a round circular complete rhexis. And another area, another initial step that's important to be careful with is the hydrodissection. So you have these air bubbles that are trapped posteriorly. So it's best to do a gentle rock and roll maneuver, bring up these posteriorly trapped air bubbles. And once you've done that, to do a gentle hydrodissection, important to be a little more gentle in these cases as compared to routine phacoemulsification. And as in routine cases, it's important to ensure nuclear rotation in these cases as well. So thank you so much. Thank you for the opportunity.
Yeah, that were wonderful take-home points you have shown in the challenges with a femtocataract platform beautifully. I'll start off with a question to you. Would you believe in having a pupil maximized scan or scanned capsular bag capsulotomy?
We usually do a pupil maximize, ma'am. Unless you expect some amount of subluxation, then it makes sense to center onto the bag. But otherwise, usually pupil maximized works well for us. So that is what we usually manage to do.
But actually doing a scanned capsule thing goes a great way because, the images are
Because you
taken
center
of both the anterior and the posterior capsule, and, you will center it on the equator.
True.
And any the expert panel could also answer this question, which I'm not sure who all are there. Mohan, I think you're there, no?
Yes.
Could you tell which type of total cataract, total cataracts would you expect uncut capsulotomies on a femtosecond laser, and when would you not do a nucleotomy at all in these cases? Which of these?
No, this all the total cataracts, you need to make sure that there are skip areas will be there. Please understand this. All types, whether it's a type 1, type 2 or type 3 cataracts, you have to look for skip areas. Don't pull out the capsule because it is never a free floating capsule. Always there is some attachment. So do it like a regular exercise as what Tushar has shown that. And near total cataracts, if you see the OCT scan, you can see the OCT scan. If it scans the entire lens, you can cut through the lens as well. You can do the nucleotomy also. And what my cutoff for the small pupil is about 5.7 millimeter. If the pupil is 5.7 millimeter, then your rhexis will be 1 millimeter less than that. Okay, about 4.7 millimeter. Beyond 5.7 millimeter, if I'm able to see, if the pupil doesn't dilate, then I will not do femto for these patients. So my cutoff is about 5.7 millimeter because I need a good offset for that also. Skip areas always look for because otherwise they you can tear and go to the posterior capsule as well.
Dr. Rohit?
Please unmute yourself, Dr. Rohit.
I think it was very nicely presented videos which Dr. Tushar did. What Dr. Mohan Rajan has said, I think trypan blue staining is a very important part in this. And because with the help of trypan blue staining, the anterior capsule becomes absolutely clear. And then you have to lead yourself in it. You have to, when you are putting in the visco, you have to be very careful about it, because if you put in the visco and you don't put the capsule rhexis flap back, it can cause, if you take it across, at times it can extend to the periphery. So you have to place it there, and then you have to see, because there are many skip areas in these. So these skip areas have to be taken care of.
Actually, it's because of the increased intraluminal pressure in some of these total interstitial cataract. So, as soon as you puncture it, the level where the laser hits is changed because of the fluid thing. And if it's a total opaque white cataract, you do not do the nucleotomies at all. You could do it with a total brown cataract. But in a white cataract, it's opaque, so the laser cannot pass through. And at the other area of a total cataract where you would not do, which you rarely see, is again a total Morganian cataract, where the nucleus is the capsular bag, or you cannot be sure how the capsular bag, anterior and posterior capsular bag are.
I can just increase the offset.
Yeah.
Yes, Namrata?
Yeah.
So in the Morganian also, if you change the offset, you can probably do it.
Yeah.
And I would even do it for a total cataract. It's a different thing that, it may or may not cut as much as I would have liked to.
Yes.
I'd also like to ask Dr. Mitra.
No, I want to add one thing, Chitra, here.
Yeah.
You'll be surprised to find that on the scan, that these cataracts cut also.
Yes.
So don't underestimate the catalyst laser, especially because it can cut even through a mature cataract. I've seen nucleus division all the way up to the posterior capsule, even in almost near total cataracts.
Near total brown cataracts more than in white.
Even white cataracts also I've seen. It cuts.
Dr. Chi from Singapore has shown there's almost a 17.2% chance of an incomplete capsulotomy in white cataracts, especially Morganian, and greater the lens thickness, greater is the chance of incomplete capsule.
Yeah, but that is not the issue, because with the closed chamber, there is no pressure dynamics. So you are able to create a partial one, but when you go in, there is hardly any incidence when you end up with a extension beyond to the periphery. So if you are careful with those skip areas and staining and adequately managing with the visco, you really have an extension to the periphery.
Yes.
Yeah.
True. Harshal,
Dr.
you go
Chitra, I
on.
wanted
Yes,
to add
yes,
one
ma'am.
quick thing.
Yeah,
Dr.
Dr.
Chitra,
Mitra.
Yes,
I
Gaurav.
just wanted to add about Tushar's one case, the first one where you were showing the small pupil thing.
Oh,
So,
I
you
have
should switch
right.
off the you can switch off the on the screen there where it shows where the rexis is going to happen. You can switch it off when the rexis is happening, otherwise you can miss where it's actually firing, because it gets camouflaged under that, and if it's coming too close to the pupil, you can stop at that point, because otherwise you'll go onto the iris. That's one thing. And because of the meiosis which happens, I would never want to go too close, intraoperatively, with any of the lasers. Actually, some meiosis does happen. Third thing, while you were doing that rexis, I felt that if you could put viscoat to push the pupil away, you could have had better visualization where you wanted to tear. You were going right under the pupil and very close to it, so either viscoat or something like a viscomydriasis, or
Yeah.
maybe even a small single iris hook there too, because the template is already there probably. And when you're tearing, if you can see where you're going, might have helped. Otherwise you handle it so beautifully, Tushar.
Which is very
Congrats.
good,
Yeah.
but I still wish that you, in these cases, you go through the side port and don't open your main incision at all. Because
Right.
some amount of anterior chamber shallowing could also cause it to run away sometimes.
Right.
So we shall
Okay.
go on to our next case. Harshal, could
Yes,
you please?
yes, ma'am. Yes. So our second speaker is Dr. Sanjay Rasal, who is a prolific phaco-refractive surgeon who is practicing for last 2 decades and in Kolhapur. And apart from being a great surgeon, he's also a great sports enthusiast. So we welcome Dr. Sanjay Rasal. He's going to present a very challenging case of cataract with iris coloboma and the way he handles it. Dr. Sanjay.
Thank you, Harshal, for the sweet introduction. And to begin with, I would like to thank Dr. Chitra Madam and team ARC. Am I visible? My slides are
Yes,
visible?
yes, please go ahead.
Yeah. So today I will be sharing, as Dr. Halsur has said, cataract surgery in iris coloboma and microcornea. During workup, if you see, the case is presented like this, and we may face challenges in preoperative period doing accurate keratometry, biometer reading, and thus the IL power calculation and even peribulbar ocular injection anesthesia will be tedious in these cases. Intraoperative challenges like eccentric non-dilating pupil and very shallow SE with the crowded anterior segment due to microcornea and bulging hypermature cataractous lens is there. So we need high quality viscoelastic iris hooks to stretch and dilate the pupil, and appropriate size CTR if at all needed intraoperatively, and 3-piece hydrophobic IOL. Now let us see how the case went. First, the side port is made, then little xylocaine is injected, the viscot is injected to deepen the anterior chamber. Second side port is made, the blunt spatula is swiped below the iris to separate posterior synechia if at all they are there, to facilitate the easy placement of the iris hooks. Total 4 iris hooks are used to stretch and dilate the pupil. The 5th one is not used because I had a sufficiently well dilated pupil to carry out the further steps here. So one can use all 5 iris hooks if at all needed. The visco is washed away. Then trypan blue is used to stain the anterior chamber. Here the remaining viscoelastic adherent to the endothelium got stained, which fortunately got cleared off with the irrigation. Again, chamber is formed with the visco and deepened to facilitate the CCC. Initial attempt to get the radial cut was failed, so I tried. Second attempt was successful. The superficial liquefied cortex and the air bubbles hampering the visibility are aspirated out. The CCC is fashioned using cystitome and microforces alternatively from either side, because entering the anterior chamber, the iris was coming in a way, so I have to try it from the other side also. Finally, I could get 5.25 size CCC, well centered. The tunnel is created. The superficial cortex is aspirated for better visibility, estimation of the size of the nucleus and hardness of the nucleus to set optimum phaco power on the panel. The center of the nucleus is buried with the phaco tip, and the nucleus is divided into 2 pieces with the horizontal chop technique. Here I always try and sub-chop the right side of the half of the nucleus into multiple small pieces with mere single hold to save the phaco energy, and all small pieces are emulsified immediately. the forces that are acting centripetally towards the tip of the phaco tip. So no strain on the zonules. All remaining left side half of the nucleus is divided and emulsified subsequently. One part of the left half of the nucleus is kept all the way in the colobomatous area to support that area. Once phaco is completed, the loose cortex is aspirated with bimanual IA, but accidentally the CCC got torn at 5 o'clock position. Fortunately, the fibrotic element saved my day on that day, and microforceps used to remove that tag curvilinear. 3-piece hydrophobic IOL is then injected into the partially into the bag and partially into the entry chamber. The visco below and above the IOL is removed using bimanual IA, and IOL is dialed in the bag so that the proximal haptic goes in a colobomatous area to support that area and keep it stretched. All the iris hooks are removed one by one under irrigation. Then finally, IOL is dialed and its position is confirmed. Entry chamber is formed with the air bubble. All ports are hydrated and class is finished. This is how the first day and 15th day follow. Patient is very happy with the good vision. So is the surgeon, and hope all you are happy. Thank you very much. Thank you for patient hearing.
That was a wonderful video, Dr. Sanjay. Can you stop? Yeah. Wonderful video. Lot
Thank
of take-home points there. Mr. Sunil, after this discussion, you could show put the entered a short advertisement. And I have one question to the expert panel. When would you all plan to place a CTR in a case of a coloboma? Any of you can tell me? Would you suggest your thoughts on that? Gaurav?
I need to answer.
Yeah. Ma'am, I think that's a great question. So there are a few instances where I definitely want to put it. I'll start from the last part, because when I'm putting a toric IOL, I always like to put a CTR in these coloboma eyes. Also, if I'm putting an IOL and that's getting decentered, or it's kind of rotating, I would love to put a CTR. And of course, during the surgery, at any point, if I feel that my the dehiscence is enough that it's causing the back to collapse, or if there is a problem in the surgery during the surgery at any point, where you feel that your handling is getting compromised, you may have to put in a CTR almost at any point. There it would work just like a subluxated cataract, like as soon as you need it, and as late as you can go on without putting a CTR. So these would be the principles that would probably guide me.
Dr. Sanjay, would you like to close that coloboma in all the cases, or
actually I did this. I did this case under topical anesthesia, and the duration of the surgery was almost 30 minutes. So I convinced that patient to repair that coloboma defect, if at all it is a concern, area of concern, because the patient had a choroidal coloboma with the posterior staphyla, including macula. So it hardly matters for the patient as far as vision is concerned, and also the CCC margin which was there, which will over a period of time will fibrose and will take care of that defect also.
Dr. Suresh has brought out a very valid thing. It is not just a CTR, but there may be times when you would feel more confident if even a CTS is placed in these kind of colobomas. We can never take them easy. And I have not experienced it, but anyone has noticed that, it is said that you could have a fluid misdirection in these cases.
That's what I wanted to say, Chitra.
In this case, CTR was kept ready, but as the coloboma itself is a non-progressive zonulopathy, and it was a less than 2 o'clock hours. So I thought better to support that area with the PMMA haptic of the IOL.
Actually, CTS probably doesn't have much of a role here, ma'am, because CTS is only used when you have enough phacodonesis or subluxation that you want to anchor it to the sclera. In a coloboma, that hardly ever happens, and by itself, a CTS would probably not help much. CTR is there to expand the bag properly and all. There's one thing, Dr. Sanjay Rasal, I noticed that in two places where you could have done something better. When your phaco probe goes inside and when your injector went inside, you caught the iris both times. So, I would have done with the left hand, kept a chopper or some manipulator ready on the side port, and, pushed the iris down a little bit when entering the chamber with either the phaco handpiece or with the injector. That way your iris would not have got traumatized.
Or just put viscoat near the...
I would have used visco.
No, viscoat. Viscoat will just push the iris back and then go without irrigation.
So,
what Chitra was mentioning about the fluid misdirection in coloboma is something which the fluid goes inside
Kind
Through
the
the effects, yeah.
hydrates the
Yes.
vitreous, then you can have more shallowing of the chamber as well.
Yes.
And whatever iris coloboma and microcornea I have seen is the cataracts are very, very hard brown black.
Yeah.
I don't know. It's a relatively soft cataract, what you have seen here, but I have seen only hard brown cataracts, black cataracts, and very difficult to do phaco for these patients as well, because the chamber is shallow, the microcornea is there, there is a zonular weakness also, there's a coloboma, multiple factors are there. But you did it very well.
Dr. Kumar.
Yeah.
Yeah, can you hear me?
Yeah,
What technique would you like to use to close this coloboma?
so you can do a photopupilloplasty, but as
Can you be louder, Kumar?
You can hear me?
Yeah. Yes.
As rightly mentioned by Sanjay, I think that, what we underestimate is the opacification of the CCC that takes over time. So if you've done in the olden days when we used to do iris coloboma and just leave it alone, the edge of the capsular rexus and beyond that would opacify. So it really wouldn't matter as far as the light is concerned. So would I really like to close? And you'll be surprised that some of them don't really matter because they've been used to it like that for years. They've lived like this.
Yeah.
Yes.
So if you need to really
One
close
more-
this, you may not need to close this.
One more point I would like to highlight here is a workup of such a patients, because having a accurate keratometry and biometry is a key. And IOL power calculation, our literature says one should undercorrect by say 1 diopter to compensate the relative anterior ELP, because these eyes go myopic if you go with the exact power. And doing keratometry is a trick. What I say is optical biometry in such cases, they don't work. Auto K will not work. So we have to believe on the manual K. What we do is ask the patient to fix the torch light which is thrown through the eyepiece of the manual keratometer. And once the torch is removed, don't ask the patient not to move the eye. And during immersion biometry, if you tilt the probe here and there, you get erroneous results, because such eyes are often associated with the posterior staphyloma, and we get erroneous results. So one should be damn sure that you keep the Prager cell exactly in the visual axis and try to get consistent spikes on the A scan, so that we will have a fairly accurate biometry as well as keratometry for IOL power calculation.
Very
I think
important.
when IOL master 700, you can do very well. It shouldn't be a problem. And I think with immersion too, you can do well.
Madam, we have Lenstar, and Lenstar doesn't work in this case.
500 IOL master, Lenstar would not work. The 700 IOL master
700 may work,
penetrate
yes.
because of the quality, the type
Yes.
of laser.
But
So
immersion
any
has
other-
given a very good results in this case.
Immersion is very good.
Yeah.
Can we
Very
see
nice.
the video of Entore, Mr. Sunil? Thank you very much. An excellent talk, Dr. Sanjay. We shall now go on to our next speaker. Our next
Thank
speaker,
you, madam.
extremely brilliant and versatile surgeon from Megur Eye Care Center, has Dr. Deepak. Could you start sharing your screen? Who heads the cataract and glaucoma specialty. He's a keen academician and has had an amazing set of awards. Watching his video will tell us again how amazing he can be. So let's hear from him. On to you, Dr. Deepak.
Hi, I'm Dr. Deepak Meghur, and today I'll be sharing with you a case about a 70-year-old man who had sustained blunt trauma many years back. Now he has an intermittent cataract with around 3 to 4 clock hours of zonular dehiscence. So I begin my case by doing 2 small paracentesis. At this stage, I'm not sure is vitreous prolapse or not. I'm using trypan blue as little as possible to stain the anterior capsule. At this moment, I see there is some amount of trypan blue which is egressing out from the area of the zonular dehiscence, and I become suspicious, and I'm now injecting a diluted triamcinolone acetate to check for the presence of vitreous. And as we can see, there is a tongue-shaped vitreous which is prolapsing from the area of the zonular dehiscence. So the first thing to do in such a scenario is to ensure that we do anti-vitrectomy and remove all the prolapsing vitreous. We can't proceed with the vitreous prolapsing out like this. So using a very low flow rate and high cut rate, I'm doing anti-vitrectomy to ensure that the vitreous is cleared off. The high cut rate and very low flow rate ensure that we don't cut the iris in the anterior capsule and they are prevented from damage. I'm plugging that area of zonular dehiscence by using a dispersive OVD. Under this, I'm using a cohesive OVD, push back the anterior capsule so that I can get a rhexis done easily. During rhexis, I realized that the rest of the zonules are quite healthy. The capsule rhexis could be done quite easily. I'm aiming to do a rhexis of about 4.5 to 5 millimeter. The smaller rhexis is going to help me to achieve optic capture if the need arises. And the rest of the zonules look to be quite healthy in this situation. So the rhexis is completed. Capsule hook to engage that area with the zonular dehiscence. I'm making another side port to introduce my chopper. Again, I'm using dispersive OVD to block that area. So now I'm implanting the CTR. I always support the ring with my left hand using a Sinskey hook. And the last part of the ring is dialed in by using another Sinskey hook. And my strategy is to do a direct chop. So once I bury the phaco tip into the nucleus, I'm trying to chop the nucleus and realize that it's quite dense. My right hand is stable and I'm just trying to use my left hand to separate the nucleus and try to break the posterior fibers. Again, the strategy is here to keep my right hand stable and try to separate the fragment using the left hand. The difficulty in eyes with these loose bags is that you don't have the counter traction which is so helpful in separating them because the tensile strength of the bag is not much here. So it is now the final two fragments are emulsified quite easily. White plaque which you're seeing behind the posterior capsule actually is the vitreous which was stained with the triamcinolone acetate which we had used, and we can see there is still some amount of vitreous being prolapsed to that area. At this point, I thought the best way to tackle this is by using a pars plana approach, because we can access the vitreous from behind and then do decent anti-vitrectomy. So 3 millimeters from the limbus, I make a sclerotomy using AMVR plate just behind my scleral tunnel incision which I had created. And again, using my 23G cutter and infusion through the antechamber paracentesis, I proceed to do a limited anterior vitrectomy. Care is taken that I remove all the vitreous which is there adjacent to the area of the zonular dehiscence. And also I'm cautious that I don't damage the posterior capsule. So just enough to ensure that it doesn't prolapse through the zonular dehiscence. This stage, I'm closing my sclerotomy using an A2 vitral. Now is the time to implant the lens. I'm using sodium hyaluronate to create some space. The plan again is to implant the multi-piece lens with the haptic in the sulcus and then trap the lens behind the rhexis margin to achieve an optic capture. So first, it's important and critical that we go back behind the lens and remove the OVD which we have used it. Once the sodium hyaluronate is removed, now we need to tuck the lens back posteriorly. And once it is done, you can see there is some amount of a vitreous which is again prolapsed through that area. I'm using my vitrector to do vitrectomy, and you can see the ovalization of the rhexis, which is suggestive of the fact of the optic capture.
I think, yeah. That's it. The case is done and the patient eventually did well. Thank you so much for attention.
That was a wonderful
Amazing.
Dr. Deepak.
Fantastic.
Now,
Very nice.
So I think, Chitra, you should ask him one first thing is that what is the recorder that he's using to
I
record?
know, exactly. Amazing.
Amazing.
I have quite a few questions for you, and I'm sure Harshul has too. And I want the expert panel also to be involved. Since you mentioned that the rest of the zonules were healthy, you could have just probably kept the capsule hooks alone and done the surgery, and then later placed the CTR because your nucleus was quite bulky. What were your thoughts on that?
Excellent question, madam. The reason for putting the CTR early was I thought it's going to tamponate that area also. We get a 360-degree stretch of the capsular bag. So I was betting on the fact that by putting the CTR, the consistent prolapse of the transzonular vitreous can be minimized, and also the fluid from the anterior side going transzonularly into the posterior segment and causing pushing the bag forward, that could be minimized. That is the reason for introducing the CTR early. Stabilization of the bag could be very well achieved by the hook itself. But the idea of putting the ring early was these two concerns: to prevent prolapse of the transzonular vitreous, and also to prevent the fluid from the anterior segment entering behind the lens, causing fluid misdirection. These are two reasons for inserting the ring early.
Yes, good logic. But since it's again a non-progressive focal zonular weakness, couldn't you have thought of keeping the IOL in the bag itself so that the haptic also stretches that area?
Yeah, that's a good valid point. That's a valid point. It could have done either way. It's optic capture was not a compulsory thing here. But at that moment, I thought that would be a better option. So it was my personal choice.
How old was the patient, Deepak?
He was 72 years.
Any specific site for doing a pars plana vitrectomy? I see one. I noticed that you did a scleral tunnel in this case. Do you do a scleral tunnel for all these complicated cases?
Yeah, in this case, I was expecting to go transzonularly because there was a subluxated lens and I needed to do vitrectomy. So I choose this area because it was easier for me to access the area where the zonular dehiscence was there. So that was the reason I chose a superior quadrant, and best posterior to that, I had the congenital flap ready to do that.
The only thing I beg to differ from you was doing vitrectomy. I felt that you could have kept your irrigation away from the area of zonular weakness in that video of yours.
Yeah, but I was sitting in that, chose that quadrant. So I'm a right-handed surgeon, so I wouldn't. That's one point I could have improved.
That area, no, that would have hydrated the vitreous more in that area. That's the only.
Dr. Deepak, what was the indication for the vitrectomy through the pars plana? I wasn't able to understand that little bit over there.
Yeah, because even after doing I was not able to clear the entire transzonular vitreous. It was still prolapsing even after putting the.
So
after doing this.
Right. What I thought is that you were seeing the translon which had stained the vitreous, which was retrolenticular vitreous, and you don't really need to remove it because it will get absorbed.
Actually, the fiber which was coming out into the side port, people were speaking, so it was documented.
Coming out.
So you were not able to clear it completely. Yeah. Perfect. Whenever in doubt, pars plana is beautiful.
And also, I wanted to know, Deepak, why you removed the capsular hooks a little earlier?
No, it was looking very stable and fine, so it was just disengaging. So I just removed it. That's the only thing. It was not.
If you want to avoid putting the CTR, you can use an expanded capsular hook. Like the MST kind. Then you don't have that fear of the vitreous coming through because yours was like the single one. If you have an expanded tip, it works like a CTR in that area.
Or the Shanks modification.
Wonderful video. Harshul, do you have anything else to add?
No, I'm just totally mesmerized by his surgeries, ma'am. We know he's a great surgeon. He produces some great videos.
Yes.
And I think everybody should learn how to, tackle these kind of cases in a stepwise manner in which Dr. Deepak has shown. Wonderful videos, Dr. Deepak.
Wonderful.
Everybody should
only
learn how
thing
to
is,
make videos.
as Chitra ma'am said, I would have implanted lens in
Deepak.
capsular bag. Only thing which, I also differ.
Deepak,
Otherwise,
you can still tell us
amazing
about your recorder.
Yeah.
Recorder, you've not told us, and 3 cheers to you. You keep your secret. You have to be.
YouTube. My YouTube channel, it has it already.
Yeah.
So, Harshul,
Very well done, Deepak.
Yes. So now let's move on to the next speaker. Our next speaker is Dr. Vanaja Vaidyanathan, who is a great cataract and corneal surgeon who has an impressive academic presence with awards and achievements, who is practicing in Jyoti Eye Care Center, Pondicherry. Dr. Vanaja, over to you. We can't hear you, Dr. Vanaja.
I would request all the speakers to stay on and not go for their lunch.
Lunch is over.
Lunch is over.
A lot of cataracts are there for lunch.
No.
Yes, Vanaja, Dr. Vanaja.
Yeah, 1 minute. I am just unmuting myself and coming back.
Yeah, we can hear you now.
Can you put it on?
Yeah, I have come.
Respected panelists, moderators, co-speakers, and my dear ophthalmic fraternity watching this program, warm greetings to all. At the outset, I would like to thank ARC for giving me this wonderful opportunity, especially Dr. Chitra ma'am for this opportunity given to me. And then going on to the video. This is a case of 60-year-old post-pars plana vitrectomy silicone oil patient who had a fibrin membrane over the pupil. So once I broke the fibrin membrane, the pupil seemed. So I decided to go ahead with the capsulorhexis without any pupil expanders because I wasn't sure whether either the iris and the cataract, how the cataract was. So when I did the hydro dissection, I found oil droplets coming. I knew the bag was not stable and there was some PC opening somewhere due to the previous surgery. So I decided to collapse the nucleus into the anterior chamber, do a peripheral chop or the horizontal chop at the iris plane. Since the nucleus was almost in the anterior chamber, I'm very careful to eat up pieces as I engage the pies. I come out, I put in some more dispersive viscoelastic, make the chamber deeper, and then I proceed and complete with peripheral chop as I started, and I complete the case in the iris plane with deepen the chamber with the viscoelastics. So I'm very careful with the chopper not to bring in the PC into the tip or the iris into the tip. And as I come out, I see the silicone oil droplets coming out and the bag is rolling up already. There are both nasal and PC openings, or rather the zonules have given way. So there is no nuclear material other than what I have just removed. It was totally, the lens itself was a nucleus. So I decided to do a scleral tunnel and put it in an iris claw lens. I make horizontal marks. And then I make sure that the enclaving is done exactly midway between the pupillary margin and the limbus, and same other side. So it's important that we do the enclaving at the midpoint of the iris so that you get a nice round pupil, and the wound can be sutured. I've given an one X suture and I'm gluing the conjunctiva over with fibrin glue. I'm doing an inferior PI, infratemporal PI, and surgery completed. Bimanual wash was already done, and not much of meddling because we don't want more silicone oil to come out, and surgery is completed. So the points here I would like to put forward is the horizontal chop, which would be very useful in not disturbing bag, which is already compromised. Iris plane phaco. When we do, we'll have to keep filling in with dispersive visco so that we don't damage the corneal endothelium. And then the iris claw IOL how the iris claw IOL is inserted midway so that you get a round pupil, and the scleral tunnel is a better option than a clear corneal extension for a stable astigmatism. And then inferior PI is important. Here, usage of pupil expanding devices like Marligan ring could be done, but I had very little time. The nucleus was very unstable, so I decided to bring it into the anterior chamber or the iris plane and then continue the phaco. So the pupil expanding devices would be a hindrance in such a case because phacoing would be difficult at that plane. Thank you. Thank you for your patient listening.
Thank you, Dr. Vanuja. I wanted, can you stop sharing? My questions to the expert audience, and of course, Vanuja could answer too. Don't you think in this kind of a little complicated case, we could have started off with iris hooks so that there was better visibility and more chance of doing in the bag phaco, number one. Number two, when that silicone oil was coming from hydro time itself, would you think more towards a zonular weakness and place a CTR then and there instead of getting the nucleus into the anterior chamber and doing the phaco? Your thoughts, Dr. Mohan?
Yeah, absolutely. I think silicone oil, vitrectomy, silicone oil is a totally different ball game. Please understand these cataracts are hard, fibrotic, and pupil is small, zonal dialysis is there, zonal weakness is there. And I would straight away, in the beginning itself, as you rightly said, put iris hooks. Because I have to see well. Unless I see well, I cannot operate well, especially in a complicated situation like this. I don't want to bring such a hard cataract into the iris plane anterior chamber. The cornea will definitely become white the next day. So I don't want to do that. So I want to do in the bag phaco. The silicone oil is probably inside, or SOR has been done. Normally, I combine
silicone oil is there, sir. And while doing hydro itself, lot of silicone oil droplets were coming in.
Yeah, normally I combine the phaco with the silicone oil removal as well. So mostly I do that. But if the silicone oil is going to be there, you have to take all these precautions. I think the primary thing is iris hooks, dilate the pupil, see well, then you can perform well.
Dr.
I think that is the single take message.
Dr. Sandeep Nagvekar, are you there? Nagvekar?
Please unmute Dr. Sandeep.
Dr. Nagvekar has to unmute.
Yes.
Unmute herself.
Right, I'm here.
Yeah, your thoughts on this case?
Well, I think she managed it well, but as Mohan rightly said, the first thing I would have done is try to get a good view of the cataract. You know, I think I would have put in hooks right in the beginning after I had separated the synechia.
And
my job
placing
would have been much easier.
Absolutely.
And placing a CTR?
CTR, yes, of course. I mean, definitely. Once I've done the capsular excision and I can see the silicone oil coming there, I would definitely put in a CTR.
I have a question here.
Yes.
Without being sure whether the PC is intact, can we put in CTR? Because you are never sure in a post-planar vitrectomy case, there can be a PCR.
You can just start off with the capsular bags, support the bag, and go ahead with the phaco. But you can have, first thing is iris hooks. Need to dilate and see the periphery of the cataract.
Yeah, iris hooks, point well taken.
Yeah. So, but I think that there is a point there, Dr. Vanuja, which she's made, that these cases, they may have a posterior capsular dehiscence or thinning and or defect. So CTR one cannot put if, you know, PCR is present. And should try and avoid
that was my doubt exactly, but iris hooks should have been put in. I accept and I take that point.
Yes.
Dr. Vanuja, you would get a history now that the cataract matured immediately after the vitrectomy.
No, it was more than 6 months. It was 6 months post PPV.
Basically, he's trying to say that the lens touch could have been a trigger. Then you need to be cautious about that.
Exactly. Yeah.
That I doubted also. Or for that matter, people give intravitreal injections and sometimes, you know, it hits the PC. And if you're not aware of it, then again, there is going to be a ring.
Dr. Vanuja,
I just wanted to, sorry. Okay.
Yes, yes, please go ahead, Dr.
No,
Luthra.
I was
Yeah.
just saying that yes, I would have also delayed the CTR as much as possible because if there's a PC rent. But if you must put it in a suspected CTR or the bag integrity is not known, you can just tie a 10-0 suture to the eyelet of the CTR and put it. You can still use it, and just in case it starts dislocating for some reason, you can just tug on it and it'll come out. So whenever in doubt about the capsular bag integrity, you can just tie a 10-0 to the CTR eyelet.
Yeah.
That's
Dr.
a very
Vanaja,
good point.
briefly, can you
Yes.
tell us about the biometry in these cases, which are silicone filled eye, for the benefit of the...
Pre-operatively, before the past planar vitrectomy, only we should make it a point to do the biometry, because post vitrectomy it becomes difficult with the silicone oil in. That is one way. Taking the biometry value of the other eye could be another option.
You could even enter
silicone filled eyes.
Silicone filled eye entry in IOL master. That also
master silicone filled
yes.
But the important thing is to know whether the silicone oil will be removed later on or not.
Yes,
Because
yes.
if it's going to be removed, it's going to change the refractive power of the eye.
Yes.
So,
yes.
So you
very
must be in
interesting
touch with your
video,
VR.
Dr.
So we can
Vanaja.
never be very accurate in these cases.
Yes.
So I think we'll
And
have
a
to
very
take one of
interesting
these
video. You
options.
brought in lot of thoughts and
Very good.
questions to come up.
Very nice.
Thank you.
Very nice.
Thank
Our
you.
next speaker is Dr. Anil Kumar Singh, consultant cataract, cornea and refractive surgery, working in Sai Surya Netra Seva, Ahmednagar. Now let's hear from him. On to you, Dr. Anil. Could you screen? Yeah.
Yes.
Yeah.
Yes, ma'am. Am I audible?
Yes, yes. You could share your screen.
Yeah. Yeah, ma'am. Basically, this all because of my guru, Dr. Prakash Kankriya, operated case 30 years back, a post-RK patient,
I think we have
48-year-old.
to share the screen. We can't see the PowerPoint.
Yeah, my screen is visible, ma'am?
No, no, no.
No, we can't see it.
Yeah, just a second.
There is that share screen.
Doctor,
below.
6 o'clock, there is a green button, screen share on the Zoom window.
Now it's visible?
No. Dr. Anil, on the Zoom window.
Yes, yes, now it's visible. Yes.
Fine. Excellent.
Yeah, so I'll be talking on a this is patient post RK radial keratomy done 30 years old, nearly 30 years back by my guru Dr. Prakash Kankriya sir at Sai Surya Netra Seva, and when we opted for this case why because this is not very tough surgery as such, but there are a few tricks where we are supposed to judge on before starting the surgery itself. Is my video playing? Yeah, my video is playing now. So when we choose the incision site here, that makes a more difference, like where the main incision should be and where the side port should be, because sometimes the wound dehiscence occurs because those keratectomy lines, they sometimes, if they are very large or they are very close, in this case it only 8 lines were there, so RK lines were there, so it was not very difficult. But yeah, whenever we are choosing our sites, we have to be very tricky. Second point in these cases is like how to choose IOL. The biometry we have to be, because what we know is in post LASIK or in post PRK, the posterior to anterior ratio usually decreases, but when in the post RK patients, what happens is this increases the posterior to anterior diameter, what we talk about. So choosing the IOL power or calculating the IOL power is also tricky. And this, when we are doing capsulotomy, that time it makes the more, what trick I use is sometimes when we leave the flap and the lines is there, that time again restarting it becomes difficult. So my trick is just tilt the eyeball a bit and we can easily do it the whole CCC. And it is central and it should be maximum 5.5, or in optical zone already reduced. So we have to be precise in that. Then after that, the rest of the phaco procedure, what we have, because they are so all our seniors are better surgeon than me, I suppose. So it's not very big deal, but here precision about taking the incision, precision about doing the CCC, the main ports, this entry side, it should come in between the two lines. If you are slightly here and there, the wound dehiscence chances there. And I remember in few cases I have put sutures also to make it secured and to keep the what we call anterior chamber well formed. So rest of the time, hydrodissection, hydrolination, since he was a 48-year-old male, it was soft cataract, and we easily we can do it. And by going on a regular setup at with FACO 2, easily the nucleus can be emulsified, and not even going to, even if you don't go to FACO 3 or FACO 2, you can easily aspirate the free of cortex left. And then the rest of the part, what is left is just cleaning of the cortex. And here also it's just a regular FACO, so not much of a difference. But prediction of what we call is incision site, the main and the side port, and CCCE, when what I mean to say, it makes a difference here, and the biometry. This is how, like, after when we are going to put the IOL also, the pressure or the trick is not to put much pressure, just slight screw movement, so that if two lines are very close, and there's chance of wound dehiscence again. So this when we are just injecting the IOL, it have to be very careful, because there should not be more vibrations also in the side, on the side lines, main lines, or the lines of the RK, and those keratectomy lines can dehisce, and then sometimes we need to put sutures out there. So that's why I'll be closing it, and this is nearly like very easy to perform, but taking care of those line dehiscence and calculation of the IOL power, ma'am. So this will be nearly finishing with the case, and thanks to whole AIOS ARC team, especially Chitra ma'am and Azul sir, for giving me an opportunity. And I have being in Ahmednagar and being in Science Surya, I do get chance to do these sort of more RK cases, because it all have been operated by Dr. Kankriya sir around 25 years back, and I have been doing cataract on these cases. So thank you very much.
Thank you very much.
Very nice.
The two main points is, like, in between RK two line incisions, you should make your main incision. So
Right.
that is one thing he said.
Can you stop screen sharing, Dr. Anil?
Yeah, sure.
So that we can have discussion.
And the other point I felt we should all know is, if there are multiple RK incisions like those in Ahmednagar incision, then it's sometimes even better to do a scleral tunnel.
Scleral, yes.
Yeah,
absolutely.
And question to you, Dr. Kumar. Now, what would you do if you have a refractive surprise in a post-RK case? Like Dr. Kumar, Doctor, or Gaurav, Namrata, anybody could take it.
I think.
Let Kumar take it.
So I've done surface in such patients if it's very, very surprising. Otherwise, you can always put another.
Normally wait for 3 months.
Yeah. Yes, that's what that's what the point I wanted to hear is, like in this post-RK, there's a lot of refractive instability which is there in the initial months. So and it could go wrong in our biometry, especially if there are too many incisions and the optic zone is smaller than 3 millimeters. So in these cases, it's better to wait for at least 3-4 months till we get refractive stability. Then we do it. Otherwise, there's a likelihood of a hyperopic shift in these cases. And
even when you plan with all the planning also, you never kind of get to emmetropia. It's always a little bit, on the hyperopic side. So that is one issue with the RK, and they have high myopia, most of them. So all the features of high myopia, like breathing pupil, like the cataract, would be harder than what your red glow would suggest.
Yes.
And then polishing has to be done meticulously, because they tend to be younger also, these patients.
Yes.
So all those things would also be there, features of myopia.
I think
Dr. Pandey has some views, I guess. Dr. Suresh Pandey, can you unmute yourself? How would you like to tackle the refractive surprise after? Can you unmute yourself?
Yes, can you hear me? Yes,
the
refractive surprise can be tackled with the piggyback lens implantation. Like I have done a couple of cases. Normally, whenever I do calculation of lens power in such cases, I always add. I try to aim for the little myopic side. So that, and piggyback lens can be one of the important way to address the refractive surprise. Piggyback sulcoflex toric or sulcoflex monofocal lens can be helpful in such cases.
Yes.
True.
And
Thank you.
any other thoughts? Any other?
Yeah,
things?
I just
Dr.
want to
Rohit
make
has.
one point.
I think the most
This way,
important
I think you rightly said, because I make a scleral or a posterior limbal incision, and I make the incision as small as possible. I prefer 1.8 or 2.2 millimeter, and even the side ports also. I would probably use Rohit's calibrated side port in this, because exactly the size I want to, and also side port also should be posterior limbal.
Dr. Rohit, you wanted to say something?
Yeah, I think basically when in doubt, you should always, the first thing is, as Dr. Mohan has said, make scleral incisions, because you don't want that the dynamics should extend to the incisions. That is the first thing. Coming to the IOL formula, I think one should go in for the true K Barrett's formula, because that gives practically the best amongst all the available formulas which we have.
Yes, very true.
Then basically what we have to realize is that in all these patients, you have to wait till it stabilizes, because there's a hyperopic shift, hyperopic surprise also in these patients because of hydration of these incisions. So you have to wait, and you have to, how you have to decide when we have reached the final refraction. You have to give yourself a chance of rule of two, they say, I believe. You have to wait for 15 days. Two refractions have to be the same at the same time of the day, because there's a diurnal variation also that has also to be borne in mind. Piggyback IOL in such cases, if it has to be done, is the answer in these patients.
Very valid thoughts, Dr. Rohit. Harshul, anything to add
Yes.
before we move on to the next?
No, let's move on to the next speaker, ma'am. So our next speaker is Dr. Mohammad Faisal, who is an extremely pleasant and a skilled surgeon, who is consultant cataract, cornea, and refractive surgeon from Eye Foundation Group of Hospital. And at a very young age, he's heading the ERODS Center of Eye Foundation, and he would share a very important practical tip for cataract surgery. Dr. Faisal?
Thank you for your nice words, sir. And thank you, Team ARC, Chitra ma'am and Harshul sir, for giving me this opportunity. I just start off going back to the basic by showing divide and conquer technique in mature cataract with average sized pupil. So the first step in successful divide and conquer lens removal is the creation of an adequate capsular axis. The axis should be no larger than 4.5 to 5.5 mm and as round as possible and centered on the visual axis. Next step is good hydro procedure, as divide and conquer technique requires rotation of nucleus. So good hydro procedure is mandatory. Then comes the phaco settings. Moderate flow, low vacuum and continuous phaco power is needed. Power used is based on nuclear density. Harder nuclei needs higher power, as insufficient power causes the phacoprobe to push the nucleus forward, resulting in zonular stress. So first, loose cortical fibers and epinucleus overlying the nucleus should be cleared in foot position 2 alone or with minimal application of phaco power. Next step is to sculpt the groove in the center of the nucleus. It is started with developed position of phaco tip. During superficial groove, sculpting should be stopped short of the rexis, and the subsequent grooves can be taken beyond the rexis rim. The entire tip should not be buried. Instead, only the half is buried to get the groove uninterrupted. The groove should be 1.5 times the width of the phaco tip to prevent the sleeve pushing the nucleus. During each sculpting motion, the morphology of the lens should be kept in mind. That is, the downslope sculpting initially should be followed by upslope sculpting beyond the center of the nucleus. The ultrasound power should be used only during forward movement of the tip, and the foot pedal should return to position 1 during reverse movement. So on the distal side, nucleus can be sculpted slightly further towards the periphery, but under the site of the entry wound, the groove cannot extend as far periphery due to capsular ring and angulation of phaco tip. So nucleus is rotated and the groove is extended. And now second groove is made 90 degree to the first groove. This may not be wider. A clear reflex in comparison to the rest of the nucleus indicates satisfactory depth. So after which you should not deepen. Once a pair of crossed groups are created on the nucleus, then next is it's a time for cracking. So cracking can be done either by two choppers or with chopper and phaco tip. Here I am doing conventional cracking. Both the instruments are placed deep in the groove and the quadrants are separated with outward and slightly upward motion. Make sure the posterior plate is cracked. If the crack is incomplete, then the instruments can be moved towards unsplit area and repeat the maneuver. So next is quadrant removal. Now the aspiration rate and the vacuum is increased to better draw the nucleus quadrant into the tip. Once the quadrants are in the center, then it is emulsified and aspirated. So in this case, as the pupil is of average size, I didn't go for a pupil expander. I mean, yeah, iris retractor, anything, and the case went very well. Thank you.
Thank you, Dr. Faisal, for bringing back to us some of those pearls which we used to really hold on to in our earlier days and still would at any time point which comes to that. I just have a question for the expert panel, and of course Faisal could answer too. You know, when you're stuck with a thick leathery plate in these total cataracts, what are your tips for dealing with them?
Dr. Luthra?
Dr. Luthra?
I think he showed a beautiful way to do, perfect 4-quadrant crack, and all the points are well taken about the width of the trench and everything. All I would like to add here is that while he was able to crack it beautifully, and most often you can, sometimes these leathery cataracts, you can keep struggling and trying to separate the quadrants and they may not crack. So the trick is that you have to go, at the bottom of the pit. Sometimes the beginner surgeon will try to crack it by trying to separate superficially, and it will not crack, and especially if it's a very hard cataract. So you have to go deep down into the trench, and you can do a cross-action, cracking maneuver as well, which means that rather than trying to separate the two instruments, to each side, you can go for a cross-action thing. And sometimes that gives better vectors or forces to crack these, very hard. And the third thing is that, usually the crack will start from the periphery, and if you're not careful, you will not get the crack almost to the center. The center plate is very important to crack, and you must ensure that the crack is reaching right till the center in the supra hard cataracts. And I'm sure other people can add more pearls to this.
Yes, I think Gaurav, you added. You almost said everything. Except for the fact that at times what happens is that you're not able to crack completely. Then you just leave it there and you keep carousing it, because what happens is you may not break it completely from at 180 degrees from one end to the other, but even if you've done half of it, you can take it exactly opposite to that and then do the other half and then join the two chops together so that you separate it. So that is one thing that can be done.
So one very pertinent question here is, yes, Mohan sir, you can reply that for the beginners. How do you judge the proper depth of the trenching? Especially in mature cataract where you can't see the red reflex, like in the NS grade 2-3 cataract, you can see the red reflex and judge. So what would you advise to the
because
beginners?
these cataracts are very thick, you need to go almost 95% of the depth. 95%. What I would suggest is you go initially, because in divide and conquer, you are using more phaco power, because every time you trench, you are producing phaco power, you're producing stress on the zonules. That is the reason why we don't do divide and conquer for such hard cataracts. Okay, because every time you trench, there is a stress on the zonules. Already the zonules are weak in mature cataracts. You have to be very careful. As you go down, please make sure that your phaco power is less. Okay, because you're going to have less amount of nucleus to cut at that time. So initially I keep it, suppose you keep it at 100%. As you go down, you keep it around 70%. If you go to the bottom of the trench, keep it around 40%. Otherwise, you can make a burrow into the nucleus and rupture the posterior capsule as well. And all other parameters, I think Gaurav has told, and Faisal has also nicely told. Only thing is, in mature cataracts, I saw him doing multiple quadrant hydrodissection. It is not necessary at all. Just do one quadrant hydrodissection. Be careful hydrodissection. There can be an underlying posterior polar element as well. and you can drop the nucleus straight away into the vitreous. Be careful. You don't have to do hydro dissection at all. You just have
Yes.
to go and, yeah, and
They rotate nicely without hydro. even.
absolutely without any
No
problem.
need.
Yeah.
Yeah.
I think the most important thing is that if you cannot see the posterior capsule, don't do hydrodissection. That is the
Yes.
concept with which you should be moving. And the second thing which, Dr. Faisal, I would like to compliment you for what you have shown, because those of you who are not in the, chopping maneuver, this can be done, and he has adequately shown how it should be done. Another important thing which was being discussed was how to separate that posterior leathery plate.
Yeah.
Multi-level chopping, as Dr. Gaurav has said, you go on, hold it, again, hold the with the phaco tip at a deeper level, and move the chopper at a deeper level and separate it, because that will put less stress on the zonules. If by any means you find that they are joined together at the stalk. So you lift the stalk slightly and you can emulsify. Once you emulsify the stalk, the pieces separate. That is another very important click which you can use at times.
I think another thing is you should try to create a narrow trench, not a wider trench. If you have a narrow trench, it helps you in, separating, cracking the nucleus more efficiently. Yes, Dr. Sandeep?
Yeah, so regarding that last point you made, the narrow trench should be done for soft cases, not for hard cataracts.
Yes.
Hard cataracts,
Because
wide
unless you make it wide, your phaco needle will not go all the way in.
Yes.
And the other point I'd like to make about sculpting, since the whole divide and conquer is based on sculpting, and sculpting is the main thing, is the main event over here, what we should do is probably turn our microscope from coaxial 0 degrees to 8 degrees. It gives you better depth, so you can visualize as you're going deeper, The other small little point I'd like to make is keep a little more vacuum, because most of us are using a combination of torsional and longitudinal. So most of the time people keep 50 and 60 millimeters vacuum, and then that thing gets occluded. So if you want an uninterrupted pass, keep the vacuum around 120, 130, or even 150, and you can have an uninterrupted pass. And you can keep on these hard cataracts, keep on sculpting till you can actually see the fibers. Then they're easy to separate. As Gaurav said, go right into the bottom of the crack and then split it.
No, but Sandeep, if you have more vacuum, you will hold the nucleus.
No,
you don't
no.
want holdability at that point of time. You
No,
want
you-
only cutting. You want only cutting. You don't want holdability.
What happens, Mohan, is
Yeah.
what happens is that you then you achieve occlusion. If you keep the vacuum low, you achieve occlusion, and you find that your pass is not so good. Try it next time. Keep a little more vacuum so you don't get occlusion.
I think the vacuum should be on the lower side.
Lower side, because if you have high vacuum, you hold the nucleus, and the nucleus will start coming up.
No, you will not hold. It's the direction of your, the direction of your needle. You're basically going to do a bevel up. So you're not likely to hold the nucleus at that stage,
You can easily
And-
go up to 100 and all, easily. And
Yeah,
it's
yeah,
totally
that's
fine.
what I feel.
I think let's move on to the next speaker, ma'am.
Very,
Yeah.
very valid points. And thanks, Faisal, for bringing back to us something valid and which has to be used at time. Going on to our next speaker. Our next speaker is Dr. Gopal Arora, who is the president ISMISIS Maharashtra. He's also in the management committee of AIOS, past president Maharashtra Ophthalmic Society, and a leading anterior segment surgeon with lots of accolades and awards. So let's hear from Dr. Gopal.
Thank you so much, ma'am.
You will have to share your screen.
Yeah.
I think we are going well on time, so we could have enough discussions, Harshul.
Screen visible,
Yes, ma'am.
Yeah.
Is my screen visible?
No.
No.
Now?
Yes, we can see now.
At the outset, let me thank Dr. Chitra, Dr. Harshul, and the entire team of ARC for giving me this opportunity. Well, this is basically a small pupil phacoemulsification. First of all, a disclaimer from me that I was not provided the pupillary expander by the surgeon where I was operating upon. So now comes the basic, because he said it might take about half an hour to get the pupil dilator, whether it's iris hook or other stuff. So I thought I'll just proceed. the basic thing that you need to concentrate upon if it's a small pupil without using a pupil dilators are that you need to stain the capsule, because you have to know the edges of the capsular rhexis where you're going at. I normally call it as the behind the pupil rhexis or a blind rhexis, since the pupil is small and you have to make a bigger rhexis before you go into the phacoemulsification part. So you need to make a rhexis which is actually behind the rhexis. You are doing rhexis on a blind procedure, but at the same time, you must be sure whether that the shearing technique, that the rhexis is not going towards the periphery. As you can see very well, the shearing technique which I'm using gives me a fair idea as to the rhexis is not extending to the periphery. Now doing a gentle hydrodissection, and as you see, just tapping at the center of the nucleus to make sure that the fluid behind has dislodged. Now, before you start with your phacoemulsification, you need to form the anterior chamber with the viscoelastics. And the key here in doing a phacoemulsification procedure is that every step has to be performed exactly in the center of the pupil. If you see, it's almost a 3 to 3.5 millimeter pupil, and the entire procedure, the phaco probe is not at all shifted beyond that 3 millimeter margin. The second key point which you must concentrate upon is it has to be a complete division of the nucleus, because if it's a partial division of the nucleus, again, when you are eating up the nuclear pieces, it's going to be difficult. So once you are separated into 4 or 6 pieces, you can just eat up. Again, the key is you need to keep the tip of the probe exactly at the center of the pupil, that is within that 3 millimeter zone. And you can eat up each piece individually after you have separated the entire nuclear pieces from one another. As you can see, this is the last piece which is being eaten up by the probe, and there is the epinuclear plate being left. Here you need to be really patient when you're doing the epinucleus or the cortical matter washout, because it is this area where you actually can catch hold of the iris margins. And this is basically an intentional, which I have not done the editing here, because as you can see, I'm holding the iris margins. You need to be really careful. You need to put in viscoelastic at times, which I have not done in this case, but it's for the beginners. You really need to put viscoelastic so that you don't catch up the iris margins, because that is basically, since you're not using the iris hooks or the pupillary dilator, you need to be really careful in this step. Rest of the step, I think it's not very important, because you can just polish. Only thing is that you need to form the anterior chamber intermittently by any viscoelastic substances. I'm more used to doing a hydroimplantation of the lens. So normally I don't use a viscoelastic when I'm loading the intraocular lens. So it's just after you have taken out the entire cortical matter, you can simply do the implantation of the lens, which I don't use viscoelastic. So that basically takes you to the end of the surgery. And since it is an undilated pupil, you can just with a Sinskey or a dialer, you can put it inside the bag, make sure, or you can just retract the iris margins if you want to be really sure that it has gone in the capsular bag. Rest, you can just do the hydration of the side ports and the main incision. So the point in showing this video, ma'am, was it is not that I am against any gadgets or toys or any latest equipments. I am for it. But if given a chance, if you don't have those equipments, you can still proceed with the procedure giving the same results. So what matters is not the machine, but the man behind the machine. Thank you.
Thank you very much, Dr. Gopal. I'm sure actually putting a pupil expansion device, can you stop sharing your screen? Pupil expansion device would actually, that extra few minutes, makes the whole surgery very convenient. But then all of us have done this with towards the end of your list. You really know more to put a place iris hooks, and you have done and got away with it. But there are some questions which I would want us to think at this point of time.
No, like, I want to know why you didn't do pupil stretching. Pupil stretching could have been done, no?
No. As Suresh Mande had said, you could have used intracameral phenocaine to whatever the extent of dilatation it provides. And
no, ma'am, He said in the beginning that there was no pupil expander, anything which
No,
was
what
available
I
to
would
dilate. Even
Pupil stretching
I
could have
don't
been
think
done, no?
intracamera. Yeah, pupil stretching is one option. Yes.
I think anyway, Dr. Gopal Arora showed
This
us
Amazing.
was a
fantastic
very
surgery.
heroic
Fantastic.
surgery. Yeah,
Because
wonderful. He's
fantastic
a
surgery
wonderful
because
surgeon. We
only
all
I wouldn't
know.
have done that.
it required a lot
No,
of
but
expertise
Dr.
to get
Gopal,
away
one
with that.
question: had it been a black cataract or had it been a very soft cataract,
I would
would you have proceeded with the
half an hour.
surgery?
That surgeon gave me half an hour time that he'll get me a pupil dilator. Can you wait? It had it been a hard cataract, I would have waited for half an hour.
Yeah, because this was the actually the perfect case for doing the vertical chopping in the center, and this cataract had the perfect density to chop it nicely. So I think the take home message should be yes, ma'am.
I would never be for pupil stretching too, because some of these small pupil could have a floppy iris syndrome kind of setting. So I'm somehow totally against pupil stretching.
Can I add one thing, Chitra?
Cataracts. Yeah.
Yes.
No, we looked at the complications of phaco in our residents,
Yeah.
and the majority of the complications were related to small pupil. So the small pupil is a very major problem, in my opinion. I think the small pupil has to be tackled. If a patient has got IFIS, a patient is on tamsulosin, right in the beginning of the surgery, the pupil has to be explanted. Because once the iris starts coming into the port, he was very lucky. Gopal is a good surgeon, very lucky. Once the iris starts coming, it's a very messy affair. And it's going to be very, yes.
Also, I think if you do wherever you get in a catch-22 situation, do hydro maneuvers. I think in these cases, if you do hydrodelineation, hydrodissection meticulously, then you can still disassemble the cortical matter and the nuclear, the nucleus itself. Of course, in this case, the cataract fortunately was neither very hard nor very soft. So it was a kind of a grade 2 to 3 kind of a cataract. So, but it worked like magic with Dr. Gopal Arora.
Absolutely.
Yeah.
A small pupil and it went effortlessly.
Yeah, Dr. Kumar wants to add something.
Yes.
Gopal, excellent surgery. This is because you're a good surgeon.
Yes.
But you must say here that you had a good viscoelastic. You can use that. You don't need a pupil dilator. If you put a good viscoelastic, it'll help. Another thing I want to tell you that all of us, in the olden times, we'd reduce our flow rate, reduce our vacuum.
Yes.
So in a high-end machine, you don't need to really adjust your parameters.
Yes.
And another thing here is that you did a bimanual IA. I don't know whether I would have done a bimanual IA. I rather would have done a coaxial IA with a Y. So that would have made sure that I got the edge of the cortex that I have removed more easily. And when I'm dialing the lens in, I would still have preferred a Y to make sure that the lens is going into the bag. Because when you did this procedure, I'm not sure whether your lens is really going into the bag or is going into the sulcus. The only way to prove it is that you have to make sure that you use a Y in the left hand, and then you dial your lens and use a good viscoelastic to expand your whole area. So if you have a good viscoelastic, then this whole issue would not, and here it's entirely imaginary that yes, you've gone into the bag, because you don't even see that line into the posterior capsule where it's sure that it's in the bag. So excellent surgery, but I would have made some changes. In the olden times, you would have to adjust all the other parameters. In new phaco machines, we don't need to adjust all this.
And one other very simple
I think, Kumar, I don't know why you said that you wouldn't do. I would still do a bimanual like he did for a small pupil.
Because you can't see
No,
the cortex.
coaxial
Still,
you
you can still,
Kumar, I agree with Namrata. I would still do a bimanual only. And you can move the pupil to the side with your...
The advantage with bimanual is with the irrigation, you can actually retract the iris and actually take out the cortex where you intend to.
Yes.
Absolutely. Coaxial also you can do that with the Y rotator, no?
I think
just retract the iris.
Y rotator, I don't know. Not all of us are having Y rotator.
Oh no, it's a second instrument. It's on the other side.
No, bimanual would be the one thing is sometimes when you're doing the IA and the pupil has become very small, you keep getting the iris tends to get caught from behind. So how would you deal with that very simple thing?
Sorry, question.
When the pupil becomes as small as 1 millimeter and you still have cortex in the bag, and you're trying to remove the cortex, you're not able to see anything. And then sometimes, taking your IA, you're aspirating, the iris keeps getting caught. You're not in the right plane. So what would you do at that time?
I think at that time you have to put viscoelastic to see, that your iris is kind of up and your...
That is where I think the coaxial is very useful, because with the coaxial, with the second instrument, you can actually retract the iris. It works like your second hand. It retract the iris, and then you can
even with a bimanual, with the second thing, you can retract it.
Same thing with the
That's
bimanual.
The irrigation is there. No, it will keep on coming there. That's the problem.
I think whatever you're used to, it works well in your hands, right? And I think the message is also that, while Dr. Gopal did an amazing job with this, but an average surgeon should not attempt this at all, because you can get into grotesque complications, and if the iris gets into your port. So only for a very, very, very experienced surgeon, I think this should be, somebody should venture into this. Otherwise, I'm sure all of us have done it, but for an average surgeon who's listening on, definitely don't attempt. If you don't have devices, please don't proceed with the surgery.
Can I just, if I'm permitted to speak, I think
yes, Dr.
Gopal made a long tunnel, which should also be made very clear. In such cases, we should not make a small tunnel. And the right visco, the tri-soft shell technique, as shown by Arshinov, should be used, because that will expand the iris. Pharmacomedriasis will be there, not viscomedriasis will be there. Low fluidics is another important thing which we have to bear in mind. As doctor, if you have to use bimanual, that is the perfect, because that is definitely better. But I'm using a coaxial, and if you have to use the coaxial, there are a few clicks in it. You should retract your sleeve more, because when you are retracting your sleeve more, you are differentiating the irrigation plane and the aspiration plane, and that helps in taking care of that. And while emulsifying, if you see how he beautifully emulsified, he was placing the phaco probe in the proximal half of the pupil. Because if you are placing the phaco probe and aspirating and emulsifying, your iris will not get caught. And you have to replenish the visco again and again, so that there is mydriasis and you are keeping the iris away. So these are the few points which I thought I might as well as add.
Dr. Rohit, one more point which I would mention is it has to be a vertical chop. You can't even imagine that going to the periphery and chopping it.
Vertical chop.
It has to be a vertical chop.
I think there were so many things you couldn't explain in such a short time, but it was perfectly done how you managed it.
Wonderful video, Dr. Gopal. Shall we go on to the next presentation?
Yes, ma'am. Yes, ma'am. So our next speaker is a young and dynamic surgeon, Dr. Karan Bhatia, who is heading the cornea and phaco department, who is assistant professor at Regional Institute of Ophthalmology, Sitapur. He is also the torchbearer of Young Ophthalmology Society of India. He is joint secretary of YOSI, and he'll be sharing a very interesting case, Capture Me If You Can. That's an amazing video. Karan, please.
Yes, sir. Thank you, Chitra ma'am, Harshul sir, and ARC for the opportunity. Just give me a minute. Yeah, is my screen visible?
Yes.
Okay. So this is a case of a pediatric traumatic cataract. So a 4-year-old boy presented with a corneal scar, a traumatic cataract with ruptured lens.
Dr. Karan,
Yes,
can
sir?
you decrease down the audio level? Yeah.
Yeah, I'll just do that. Just a second.
Yeah. Please restart and half the music volume. Yeah. Please share again.
Yes, sir.
Yeah.
So this was a case of a pediatric traumatic cataract. That's why I've labeled it "Capture If You Can," inspired from the movie "Catch Me If You Can." So this was a 4-year-old boy who presented with a corneal scar, a traumatic cataract with a ruptured anterior lens capsule and lens matter in the anterior chamber. So the initial challenges are the IOL power calculation, the presence of a corneal scar because of the visibility and the dehiscence, a ruptured ALC making rexus difficult and compromised, the presence question mark of a posterior capsular opaque, and also the status of the PC, which is unknown in such cases. So let's take a look at the surgical video. So the incisions were made and they have to be planned into the right proper place. Staining was done of the ALC, and you can see that there is some lens matter that is outside, which was aspirated. After that, this ALC tear was converted into a rexus using a micro scissor and then Haldipurkar micro rexus forceps. So you have to be very careful. Since it's a pediatric cataract, the forces will be difficult over here, and they have a tendency to go to the periphery as well. So you have to bring it towards the center as much as possible. And such traumatic cataracts, they have a lot of plaques. So there's synechiae, there is plaques over here. So this plaque was then, fibrous capsule was cut with the micro scissors again. And you can see this. And once this was done, IA was done. And this these are soft nucleuses, so they just, or soft cataract, they just come out, and the IA was completed in the normal fashion. I prefer the bimanual, but you can see over here there's a posterior synechiae. So this was broken, and then there was a plaque over here. So this was cut with the micro scissors, and then again with the micro forceps, it was peeled away from the posterior capsule. After injecting OVD, a 3-piece IOL was implanted into the bag. So there is a tear of the ALC over here, but still I felt it was good enough. So after that, in such cases, it's a pediatric eye, a small patient, aged patient. So PPC was done because the patient will not cooperate for a YAG capsulotomy later on. So there are two ways to do this. I do like doing this with a vitrectomy cutter. So this PPC was created, and then later on this PPC was expanded on, as you can see. The IOL came out a bit, so it was again put in position, and you can see the anterior axis and the PPC, which was very nicely delineated. All the ports were sutured, which are mandatory in pediatric eyes. So this is what it looked like on POD1. There was a surprise. So this haptic was stuck at the iris and it came out because this is the area where the ALC was torn. So avoidable challenges could be the IOL stability and the resurgery because the patient has to undergo G again. So comparing the slit lamp image to the correct orientation as you would want it, this IOL was then redialed because it came out of that area. Now I want to put this IOL, I want to give it a more stable position because of the deficient ALC. It's going to come out again and again. So this was first put into the bag, followed by this was captured behind the optic was captured behind the posterior capsule. So this gave a good stability to the eye and therefore it would not rotate now. This synechiae, imagine it formed in POD1 itself. So this was then closed. The case did pretty well. And the patient had a BCVA of 6/6 and a UCVA of 6/9. He presented to me last week also, doing well. So long-term challenges are visual rehabilitation and amblyopia therapy in such cases. To conclude, IOL power calculation needs care. A 3-piece IOL is recommended. Pediatric cataracts PPC is recommended. Pediatric traumatic cataract with compromised anterior axis with PPC and posterior optic capture is recommended. And I would say that it's important to discuss with pediatric ophthalmologists such cases. They can give you a lot of tips. And there is a need for early visual rehabilitation with glasses and amblyopia therapy, which can be critical in such cases. Thank you so much.
Can you stop? Excellent video, Dr. Karan. So many things to discuss. Is Dr. Deepak with us? Dr. Deepak Meghur? Dr. Deepak is there or he's left? He's not there, huh? Okay.
Yeah, I think he's not there.
Okay. Actually, Dr. Karan, Dr. Deepak has some wonderful YouTube videos about how he has dealt with. I wanted him there for the next case. That band which you cut, in these pediatric cataracts, when there is some element of, there's a trauma, there is a fibrosis, it actually makes sense not to cut the band. And already you had a rexis extension. You could leave that band, cut it for the end, complete your rexis, because that sort of prevents the rexis extension actually when you're doing that, because these cataracts, these capsules are so elastic. And I wanted the opinion of the expert panel. I would prefer a PCC should be done manually than with a vitrector.
Absolutely.
Because the manual vitrector is more resistant to stretch than done with a vitrector, than a manual PCC. Your thoughts?
Chitra, can I add?
Yes.
Yes.
I would 100% agree with you, Chitra. Manual posterior capsulorhexis is what I do. I don't do with the vitrector. The problem is with vitrector, you don't have any control.
Yes.
Okay. And whereas manual rexes, definitely posterior capsular rexes, the control is better. It is definitely stronger. And otherwise, the case, I think all the other points he did so very well.
Yes. Any question on this? Of course, the PCT should not be large.
Dr. Kumar wants to add something.
I wonder why didn't he do a posterior capture? Why didn't he capture the optic behind the PCC primarily?
Karan, what was the age of the child? Another thing is, what was the
4 years. 4 years.
Okay.
Karan, why did you do that?
Sir, I was not very comfortable with it. As one of the points that I have raised is, I rediscussed this case with my pediatric ophthalmologist, and then they gave their tips. So that is one of the points that I had said, discuss with your pediatric ophthalmologist and any expert surgeon that is there who's better equipped to such cases, and then you can learn more.
So I think less than 6 years, we always do a posterior primary capsular rexes and we capture them. I remember Dr. Vasavada's paper, where in the initial paper he had said that don't capture because it will cause a lot more uveitis. But the subsequent publications, he said that with the newer lenses and the newer variety of lenses and haptics and optics now which are available, we should always capture in the posterior capsular rexes.
What is the size of the posterior capsular rexes, Karan?
Yes.
It would be around more than 3.5 or 4, approximately 3.4 mm.
It shouldn't be too large because the IOL will not be stable again.
Yes,
One more thing is, did you do an anterior vitrectomy at the same time? Because
you use the cutter, no?
If you don't do anterior vit,
No, he's used the vitrectomy cutter, he would have done it. He would have done it.
Yeah.
Anterior vitrectomy also, it is said that you do 2 millimeters all around in pediatric cataracts and 2 millimeters depth. So it's a very shallow kind of an anterior vitrectomy. It's not.
This was actually the first time I had used the cutter to do a PPC. But yes, as Mohan sir has said, I also prefer the rexes. And I have another case of mine, which because of the paucity of time, I couldn't show. There was a PPC with a plaque or something, adult case, where I have done to convert it with the rexes forceps only. It gets around.
The reason why I'm telling that, Karan, initially I was doing with the posterior with the cutter long time back. I'm talking about 15, 20 years back when I used to do a lot of pediatric cataracts. And I tried to capture this gimbal technique wherein capture the optic. The rexes just extended.
Yes.
Yeah. So I think the posterior capsular rexes with the cutter is not as strong as the manual capsular rexes.
If you don't have to do a capture, then you can do with.
Then you can do that. Yes, you can do that.
If you have to use a cutter, I would be wary of capturing it. Yes, absolutely.
Absolutely.
Dr. Gaurav, your thoughts on it? Because you had been into posterior segment in the initial stages of your.
I actually completely echo what you said just now. So I was going to say that, and then you stole those words. So I think, but he showed a beautiful surgery, and I think take-home messages are all very clear. And yes, when you're caught in a situation that probably you want to ensure that lens is in the bag, and you're concerned about the posterior rexes not happening well, or you're not great at doing a primary posterior rexes, you can put the IOL in the bag and then go from the side and do the posterior capsule, as long as you're not planning to capture it. But agreed completely that what you said over there, Dr. Rohit.
Yes. Good. So
Very
I
nice.
think we go on to our next case.
Yes, ma'am.
Our next speaker is Dr. Soumya, who is the director of Lopamudra Drishti Eye Hospital based in Coorg and has special interest in cataract and refractive surgery. So let's hear from her. On to you, Soumya.
Yes, ma'am. Thank you. Is my video visible now? I haven't played it yet.
Yeah,
we can.
Thank you. At the outset, I'd like to thank AIOC, ARC, especially Dr. Harshal and Dr. Chitra for putting together this wonderful program and having me on it. So I'm sure most of us would heave a breath of relief by the time we're done with handling our nucleus and mature cataracts. But really, it's not over yet, and there is so much more to come sometimes. So this is a fellow operating on a mature cataract at the end of a long day and a long list. And I can say this because this fellow was me many years back when I was a fellow in training. So I've started doing the irrigation aspiration, and probably because of the fatigue, or probably because the eye was not trained to see at this point, I go ahead and slightly aspirate the fornix and cause a zonular dialysis there. And obviously it hasn't come to my notice, and then so I go back again and repeat the same thing without noticing it a second time. In mature cataracts, we know that sometimes there is some pre-existing zonular dialysis, and the phonics is not as great as in other cataracts. It's not as strong, the zonules. But the third time when it happens, it's definitely iatrogenic, and fortunately, it has finally been noticed at this point. And obviously, because of the scare, abruptly let go, and the irrigation aspiration port, the cannula have been removed. But it's very important when you notice zonular dialysis to make sure there is some viscotamponade before removing the irrigation port. I would probably now inject a dispersive viscoelastic into the capsular bag before removing the irrigation port, if this were to happen at if it were to happen in a case now. So following this, the ideal thing to do would be to inject a CTR at this point. But I just went ahead back then and continued with irrigation and aspiration, the cortical aspiration. Like I said, now I'd probably go ahead and implant a CTR before I did this. But fortunately for the patient, Lady Luck was on his side, so it went well. And in this case, I've then gone ahead and implanted a CTR through the side port. But at this point, I actually prefer to use the CTR injector. I think it is by Epsilon, and it has totally changed the game for me. It's made it extremely convenient. So I don't do CTR implantation through the side port anymore. I use the injector. Like you can see now, the CTR is being implanted into the bag. Which then, of course, this was a fairly large zonular dialysis, but I think the CTR took care of it in this case. Following CTR implantation, an IOL implantation under visco. My single piece lenses I usually do under irrigation, but if there were a zonular dialysis in a case, then I'd probably make sure it has visco when I implant the IOL in the bag. And in this case, of course, it had a side port tear as well, so that had to be sutured. And in cases with zonular dialysis, especially these large ones, it's always a good idea to stain with triamcinolone at the end of the surgery to make sure there is no vitreous in the AC. And then, of course, a good visco removal has to be done. Thank you.
Thank you, Soumya. That was a very nice video. And could you stop sharing your screen?
Okay.
Yeah, fine. Yes, as she had already pointed to all of us, before removing our instrument, we need to inject, keep the anterior chamber stable and inject viscoelastic and then only remove. The only thing I felt deferred is, whenever I would place a CTR, I would go into the second port and ensure that I tuck the last segment of the CTR into the furnace instead of just doing it as a single-handed procedure. I want the thoughts of expert as to what they would like to add. We start with you, Dr. Namrata. You have anything to tell?
So I thought that was a nicely done case as a fellow, Soumya, especially when you have an endocapsular ring. And I always say, even to our fellows and residents, what actually happens is that they get to do it in the end. Fellows and residents should be, given table OR space right in the beginning, so that, because for them, one case is the only case that they're going to do throughout the day. And for us, we'll do so many. So that is one thing. And second thing is that I would more rely on the cohesive viscoelastic if I see a zonular dialysis rather than a dispersive one, because that would kind of expand the bag also. Endocapsular ring, you showed it through the side port, but like you said very rightly that we would use it earlier than later. And I would do it through the main port itself rather than through the side port. And you did implant this kind of intraocular lens, but I would have probably done a 3-piece IOL.
3-piece.
Yeah, rather than this thing, because the zonular dialysis was large, and although endocapsular ring did take care, and I'm sure post-operatively it would have been okay, but I would be happy to use a 3-piece intraocular lens.
Yes.
Can I say something, Chitra?
Can I say something?
Yes, sure.
Yeah.
So point here is that what she said is right. Actually, you have to inject the endocapsular ring opposite to the area of subluxation.
Yes. Yes.
That's the reason why the islets of the endocapsular ring will come to the opposite area of the subluxation. Sometimes we make a mistake of injecting the endocapsular ring in the area of the subluxation, then the two islets will come in the area of the subluxation.
Yeah.
So it's nothing wrong in injecting it through the side pot, because it's okay, because you have an injector. Now the injector, if you're using an epsilon injector to put in an endocapsular ring, the endocapsular ring has to be so malleable. If you try to put an Indian endocapsular ring through an epsilon injector, it sometimes cracks. So I have experience of that cracking. You can talk about your experience now, since you're already an experienced surgeon. But I've seen this, that sometimes it cracks, and that's the reason why the endocapsular rings, which are made in India, are not as malleable as the Morsher endocapsular ring. Actually, the endocapsular ring injector was invented for Morsher. And that's the reason why those injectors are different PMMA, completely different material.
Yeah, I think you are right. I also use through side port, as Dr. Deepak showed, no, use the Kuglen hook or other instrument to guide it while you are inserting it. So that works very well.
Can I say something?
Yes.
Yes, Mohan sir.
No, this beautifully managed. Once you see a zonal dialysis, the viscoelastic of choice will be sodium hyaluronate.
Yeah.
Because that's a cohesive viscoelastic which is available in the Indian companies, cheap varieties are available. It'll expand the bag. Then you'll have a space between the anterior and posterior capsule, you can put the CTR. That is second point. Second point is, once I see a zonal dialysis one side, I inject viscoelastic, come out, then immediately I put a CTR there and close that area.
Yes.
Okay, then I go and remove the cortex from this side. And so these are two things I would have done differently.
And that was a fairly
True.
large dialysis also.
Yes.
Yeah. So would you like to go for CTS segment, sir?
No, I think
Or a
because
CME?
the CTR itself, it was about 4 or 5 clock hours, if I remember right, the video.
Yeah.
Four
Was
clock
about
hours.
5 clock hours, I thought.
5
it
clock
was.
hours. CTR would have been okay.
Dr. Rohit, Gaurav, anything to add? Dr. Sandeep, you're so quiet.
I think the only thing,
Dr. Sandeep is muted also, so we can't give.
Soumya showed everything beautifully and explained all.
I'm learning so much, Namrata.
But I think the only thing for a beginner phacosurgeon I would suggest is that if you're doing a case like this where the pupil is a little small, you should try not to go under the pupil and do a blind aspiration at the equator of the bag. Then that's when these things happen. And also, you should always do it under visualization. You can always move the pupil aside, like with your second, if you're doing a bimanual, you can just move the pupil to the side when you're going to aspirate, have a temporary visualization there, and then aspirate under visualization. That's how you can probably prevent this from happening. I think the management part has been covered very well anyway.
Yes.
Yeah, I think there are two types of, for all these patients, when you come across who have these mature cataract with, these cortical strips lying beneath the capsular axis. For the youngsters, I would like to add that they should not be over aggressive in taking them out, because at times there is a weak, zonular thing. And if you use more vacuum, you can end up with such zonular dehiscence. I basically put an IOL, and I prefer to err on the side of leaving behind some small strands of cortex rather than trying to take the whole cortical material out. How would the other panelists say about what I have just said? Dr. Gaurav, would you like to say something?
I completely agree, sir. I mean, the small remnants which are very sticky and which are not, amenable to easy aspiration, you can easily inject the lens and be safe about the lens kind of tamponading the equator of the capsule, and that way you are safer. Another thing that I do is that if I'm not able to aspirate from the equator very easily, or if there's something, in the periphery, sometimes you have these fibers stuck to the PC and they are not ready to come off and you don't want to peel them off, you can go from the main port with just the infusion on the bimanual and do a kind of like a flush. It's like a jet. I call it as a hydrojet. And you can use that, like a direction of the fluid in all those equatorial areas. It loosens up all these fibers, and then, they're more amenable to be caught and aspirated. So that makes life very easy if they're not very free. So I completely...
That is easier, Gaurav, with intact zonules. With zonules being compromised, I don't know how much will work. But the best thing is to put the lens inside and then aspirate, no, at the end.
Yeah.
I also go.
Don't be very aggressive in removing the cord. That's a take-home message. Rohit rightly said.
Can really bring down your vacuum, go on that PC polishing mode, and then you are able to be comfortably go on to the
And tease it rather than pulling it out.
And
True.
another thing with Chitra, I want is absolutely a 3-piece lens in this situation.
Yes. Yes.
I think, Chitra, there are 2 or 3 questions on the YouTube also. So one is very quick. Karan, how old was the trauma? Somebody is asking.
Harshul,
Not there.
please open
Yes.
the moderator thing.
Yeah, I've opened it, ma'am. All the questions are already answered. There is,
Would you
first
prefer
let
doing a
Dr.
PI?
Karan answer.
Would
Karan,
you,
are you there?
would you prefer doing a PI in such cases of traumatic cataract? That was another question. So
Yes.
Karan can answer that. But PI, I don't think. I don't know. Routinely, we are not doing. Even if it is a traumatic cataract.
So one more question is there. I think Dr. Rohit can answer this question. Tips for phaco in soft sticky cataract in mid-dilated pupil in diabetic patients. So Dr. Naresh Rohra is asking this question on our panel, sir. Dr. Rohit, are you there? Dr. Sandeep, you can answer that, please.
Tips for removing? Sorry, I wasn't attentive.
Tips for phaco in soft sticky cataract in mid-dilated pupil in diabetic patients.
Well, if you have access to pupil expanders, you should use that. And you should never hesitate to use a pupil expander in any case where you don't feel very confident. But if you're in a situation where, like what Dr. Gopal Arora was, and you really don't have access, then in that case, you should make small trenches in soft cataracts and mix small as at the same time deep trenches so that you can go deep inside. And once you have managed to divide the nucleus at some stage, then nuclear management becomes quite easy. The trick is to basically get a crack. And for that, you'll have to make deep trenches and a divide and conquer, as one of our previous speakers was saying.
Yes.
Make the rexus slightly bigger than the pupil. Harshul.
Correct, of course. Yeah.
Make the rexus slightly bigger than the pupil and do a hydrodelineation in soft cataract, hydrodelineation and a hydrodissection. Okay?
Yes.
And once you do that, then everything will loosen up and start coming into the anterior chamber. You can just aspirate this thing with low parameters as well.
Perfect.
Yeah.
Dr. Karan can answer that question, Namrata ma'am.
How old was trauma in that case? Karan, how?
Ma'am, it was about 3 months or more. First, we had done the tear repair, followed by later on by this second surgery.
And did you do a PI in that case? That is another question.
No, ma'am, I did not do a PI. I did not do a PI.
All right.
What would be the recommendation for the panel? Would they do a PI in such case?
So I think I answered that I wouldn't. And
sorry, there's a connection issue here.
Confident of lens in the bag, I would not do a PI.
No.
Because lens is not the bag, then I will do a PI.
Would we go on to our next speaker? Namrata is going to be very happy because you're going to finish well before time.
Okay, let's move on to
yes, Harshul.
Let's move on to our next speaker. Our next speaker is Dr. Prajakta Deshpande, who is a very skillful cataract and refractive surgeon, and she is director of Shri Ramakrishna Netralaya, Thane, Navi Mumbai. Dr. Prajakta, can you start your screen sharing?
Thank you, Dr. Harshul and Dr. Chitra ma'am and team ARC for this wonderful opportunity. I'm just sharing my video. Please hold for a second.
Dr. Prajakta, you need to open the PPT presentation.
Yes, please hold for a second. I'm doing that. Is my video visible?
Yes. Please go ahead.
So this was a 75-year-old gentleman who had a partially absorbed mature cataract with a thick plaque under the anterior capsule. So I decided to go ahead with SICS. I made a scleral tunnel large enough for the delivery of the nucleus. Stained the capsule with trypan blue. Entered the anterior chamber with a keratome. and extended the tunnel. So while doing rexis, I noticed that the capsule was very rough and it was completely stuck to the underlying thick plaque. I wanted to make a large rexis in the first go itself, but the capsule wasn't moving very easily and my rexis became small. The capsule was very much adherent to the underlying plaque. Then I had to make a double rexis. And finally, I could get the required size of the rexis. As you can see, the anterior capsule was very much adherent to the underlying plaque. I tried to remove it with the spatula. Then I tried to dissect it with a needle, but I could not. Finally, I had to cut the plaque with a forceps, with a scissor from all the sides. The plaque got released now. I removed the plaque and then the nucleus was free from all the surrounding structures. And I could easily deliver the nucleus in the anterior chamber. I injected visco above and then below the nucleus. And with a irrigating wet disc, I delivered the nucleus out of the eyeball. As you can see, the nucleus was quite hard and brown. It had a brown core. Since it was a partially absorbed cataract, I wasn't expecting much of a cortex. So I just visco expressed whatever cortex was there in the bag and placed a 6 mm lens inside the bag. As you can see, the plaque was still adherent to the rexus margin. Initially, I tried to remove it with the eye. It did not come out. Then I just tried to dissect it with a spatula. I could not remove it. Finally, I had to hold it with a forceps in one hand and then dissect with a spatula in the other hand. And then this was a small thing I learned from this case. That is, for removing such type of plaque, you need to use both the hands, and holding and dissection should occur simultaneously. I managed to remove all the plaques. I cleared off the visco from the anterior chamber. Hydrated the tunnel and the side ports, and cauterized the conjunctiva. And this was the final result. Thank you for the patient listening.
Thank you very much, Dr. Prajakta. That was a wonderful video and lot of question to come up.
Thank you, ma'am.
I wanted Dr. Deepak Meghur to have joined in for this case. Is he there, Dr. Deepak?
Yeah, I'm here. I'm here.
You're there. See, this incidentally, of course, was not as fibrous, but she did have a lot of difficulty. You know, she had to cut the subcapsular plaque and to remove it, and a lot of extensive dissection was done, which made me wonder whether the zonal integrity could have got compromised. What would your thoughts be in these dense cataract with subcapsular plaque?
Yeah. I think there are two different variants we need to differentiate intraoperatively itself. One, if it's purely fibrotic and there is not much of an underlying plaque here, the best instrument would be either to use a scissors, and vitrector is an ideal option here. Using a vitrectomy cutter is an excellent device to use in these fibrotic variants. If you're not able to dissect out the subcapsular plaque. If you're able to dissect out the subcapsular plaque, you dissect it out and then enlarge the rexus. But sometimes if it's the fibrotic band have already gone towards the periphery, it might not be possible for us to dissect out this plaque. Then in this situation, using a vitrector would be a better idea to deal with it.
Oh, okay.
Absolutely.
Yes.
Also, I think in these cases, if you have to actually cut it and you use a micro scissors rather than this instrument, which is a big blade, then you open it inside, then it can get a little clumsy. So if you use a micro scissors which just opens inside, then it is a lot easier.
Vitreous scissors.
Yeah,
Use
your retina people use those scissors, the
yes, use that.
ILM scissors used for ILM. Even
Yeah.
those scissors are quite good, even if you don't have a dedicated micro scissors for this. But the best part was the way the nucleus came out. I mean, sometimes
Yeah, that's what.
why do you struggle with such a hard cataract and try to phaco it in one
Yeah.
session,
I felt
the
that
nucleus came out.
SICS was amazing.
Yeah, it was very.
Doesn't come out so easily the way she's anyway.
Beautiful.
I think
Can I
this.
add one point? I would have done a phaco because this rhexis doesn't extend at all. It's a fibrotic rhexis. It doesn't extend. So you can actually do a phaco without any problem.
No, but the take-home point from what Dr. Deepak said is ensure that we separate the subcapsular plaque and then only go on to enlarge our rhexis.
Absolutely.
Because you would not go wrong that way. And of course, use a vitrector.
I think there are two things, what you should do to separate these plaques.
Yeah.
The first is the dissector which was being used was a very gross dissector.
Yeah.
The dissector which we use to open the incisions of the femto incisions, that can be used to, to open, to create a plane and then enlarge it. And you can use a thin visco dissector also to go underneath it once you have a small one, and then you can enlarge it. Such a large dissector usually doesn't help. Dr. Deepak, do you agree with me because you are very much into it?
Yeah, absolutely, sir. I agree with it. I would prefer a flat spatula, like an iris repositor, micro iris repositor. It's very thin, and then you have to create a plane, a cleavage plane. And one blunt dissection, once you create it, then you inject dispersive OVD into it. Then it separates. Then again blunt dissection. That's going to work.
And I think that's the most important click. Yeah, absolutely.
The incision opening is a good idea, Rohit.
Can I add 1 point or 2 points actually? What I feel is the two-hand technique is an excellent thing, and the surgeon has showed that she has got a lot of skill, because you can easily pull away the bag, and if you put a lot of pressure. We do encounter a lot of such cases. Everybody does, I guess, in the cam setting particularly. So sometimes when I have seen that the scissors also does not cut it, or the micro scissors or any scissors doesn't cut it. So I have sometimes cut it with a keratome knife also, which works pretty good.
Yeah. Sometimes it's so fibrotic, you have to put an MBR to get a small, small area of separation, which can then be dealt with the help of scissors.
Yes. Thank you very much, and thanks for all your inputs, and Dr. Deepak too, which was very valuable. Our next speaker is Dr. Shakil Singh, who is the head of the Department of Ophthalmology from Sri Guru Ram Das Institute of Medical Sciences, and is also the Director-in-Chief of Dr. Shakeen Eye Hospital. He's also the President of Punjab Ophthalmic Society, an NABH assessor who's seen everywhere, doing a great job of his. And of course, he holds many more responsible posts in different societies, and he has a teaching pearl for us. On to you, Dr. Shakeen Singh.
Thank you, ma'am. Good afternoon, everybody, and I must thank ARC to give me this opportunity to share my ideas.
Doctor, can you be louder?
Louder.
Yes.
Okay. The topic given to me is the cataract nigra, so also called gutta serena, and I would not go into detail of this biochemistry change in the cataract. And planning to conquer this successfully is my take is to have a dispersive visco, or maybe a sharp cell technique, a well-dilated people, large rhexis, sharp chopper, and with a chain strategy that's eat the bulk, deep trench to reach more than 80% of the depth, as has been shared earlier by Dr. Mohan Rajan and other people. So break into multiple small fragments so that they can act as a cushion over the tip to avoid an endothelial damage, and a high power and a vacuum. So these are slightly changed setting in my phaco, and there's an increased on time as compared to my normal setting. I increased the on time more to 70%. So this is the one first case I'm going to share.
Not able to hear you, Shakeen.
So this is the first case I'm going to share with you. Is it? Am I audible?
Yes.
Sir.
the usual capsulorhexis, which is this. These steps are common in all those
So
cases.
you're not audible at all, Dr. Shakin.
Should I do it again?
Yeah.
Am I audible now?
Yeah.
I think you should keep holding the mic in your hand, sir, close
Yeah.
to your mouth.
That's what.
Yes.
So I'm going to reach the tunnel now. So you have to have a deep trench, and my aim is to have a 100% break. So it's a deeper trench to reach the other sides, and definitely understanding the physiology and the physiology of the lens being deeper in the center. I would reach the other side, maybe a more length in the mid, and rotate and repeat the same onto the opposite side, and breaking into 2 and a 4 then. And then you can use the chopper to cut off the vertical chop and the horizontal chop simultaneously combination, and pull out the fragment out of the bag. That would help us to eat, break, chop, and eat away. So this fragmentation, covering the tip, breaking into small pies, and then eating. And I'm preferring my burst mode. I hold the fragment, and then I shoot the power with a burst raised to 70% of the on time, so that there's less of the endothelial damage, and eat away the harder part. These nuclei, they're different from the normal nuclei, which is harder, and they are leathery, would not be able to be torn away or would be eaten away. Luckily, this nucleus which I'm sharing is not that leathery to look in, but few cases they really trouble you. And for those, we have different techniques to go on. So less of the cortical part would remain here because there's a very thin remnants there. So with a simple process, you aspirate, and I always use a coaxial. My technique is always coaxial. I don't use bimanual. And like it was shared in the previous meeting, previous talk, I always protect with my hook, so that if the pupil is not cooperating. So this is the second options with me. Like in the harder cataracts which are leathery in appearance, you may have to struggle with the nucleus fragmentation or chopping. So in these cases, I have my own design chopper with a side cut, horizontal side chopping technique. You hold with the nucleus with a high vacuum, and then you cut from the side with a side chopping, side cutting chopper, and it would break the nuclei into smaller fragments. You see, it's easy to handle. Maneuverability is much better as compared to the reverse cutting or other choppers. And you can fragment it easily, and you can get the things done away. And the aspiration and the lens dialing in, and we are through the process. Safe, you are through. Thank you.
Thank you. Thank you, Dr. Shakin Singh. Can you stop sharing your screen? Yeah. Question to my expert panel. Would you believe in doing phaco in all grades of cataract, or would there be a time when any of you would think of converting it to an SICS?
Shall I answer?
Yes.
If the pupil is dilating well, the cornea is healthy, I will do phaco for all patients, irrespective of the grade of the cataract. So that is the thing. The only thing is all the parameters Shakin has rightly said. I'll use a sharp chopper. I have the 2mm chopper with me, which is made by Apasamy. Go all the way down, wide and deep trench, very important. And then cut the cataract into as many small pieces as possible before you bring them up. Very important. Otherwise, you'll have a cornea which is white the next day. Now and then inject viscoat, dispersive viscoelastic into the anterior chamber, and make sure that you protect the endothelium and protect the pieces from touching the endothelium as well.
I think Dr. Mohan Rajan summarized it very well.
Very well.
Viscoat, I think I would first thing I would do is put viscoat to cover up the thing. And multi-step chopping, which I think Dr. Rohit Om Prakash also referred to in for the previous presentation, works well for black cataracts such as this.
And if you're using Centurion, Dr. Gaurav, how would you the proportion of torsional and longitudinal?
So in fact, Dr. Chitra was going to say that, I would do phaco as long as I had a good machine, because
Yes.
if I was struggling with an old machine, I would definitely do an SICS instead. So if you have one of the modern machines which cut really well, which have very good fluidics and which are very endothelium friendly, I would definitely prefer. And I definitely like to use 100% torsional, but sometimes on the Infinity we would get that the tip would get blocked. But with the balance tip and all, it rarely gets blocked. And you can add a little bit of linear if you want, but mostly I think even with 100% torsional, it works. The only other thing I would like to add here is that even I would prefer to do phaco in almost every grade of cataract if I had the right machine with me. And the second thing that I would do, the woodpecker technique. It really helps because, I think when very supra hard cataracts, you can embed your chopper, and rather than using the forces of the chopper to crack, once you've embedded, you've embedded the phaco tip and you have embedded the chopper, you can give 2-3 bursts of phaco power with the chopper pressing the nucleus against your phaco tip. And as you give those bursts, it works like the woodpecker thing, and it cracks the nucleus very easily. And you can do this repeatedly, and rather than struggling with the forces of lateral separation and trying to chop, sometimes it doesn't. A burst of phaco energy at that time really helps because it cracks it much better.
Very good. Anything else, Dr. Rohit, Dr. Sandeep?
I think it was.
Go on to our next speaker.
I think it was a beautifully presented talk by Dr. Shakti.
Yes.
Yes.
Staining is very important of the anterior capsule. If I'm asked to, summarize things, larger rexes should be done more than 5 millimeter, 5.25 or 5.5. And you can, retract this if you're doing direct chop. You can retract the sleeve more, which will act as a dipstick. Because, in the center of the black cataract, which is anterior-posteriorly, the anterior-posterior length, thickness is more. It is 4, 4.2, 4.5 at times. If you retract maybe till 2 millimeter, that acts as a dipstick. So you can start from the proximal half, go right into, and when you find that your dipstick, which is the phaco sleeve, which is retracted, when you go fully deep, then you can chop it with the great Dr. Mohan Rajan's chopper, the 2 millimeter, that pointed one. And the most important click is that there should not be any, wavering of the nucleus fragment when you are trying to separate, because that can put stress on the zonules. Because in these black cataracts, we are at times, we have weak zonular apparatus also. That should also be borne in mind. And when you are doing the last piece, nuclear emulsification, you're using high fluidics at that point of time. You should step down your fluidics, because in the post-occlusion stage, you can end up with a posterior capsule rupture. So in that situation, you can at times put in an IOL scaffold, or that's the second thing which you can do. Otherwise, it was a perfectly, done.
No, I would not advocate, Rohit, I would not advocate a direct chop for black cataracts. I would do a trench. Okay, I'll do a wide and trench, and then go into the bottom of the trench and then chop. It makes life easier in black cataracts.
But if you are a direct chopper, as quite a few of us would be, the clicks I have explained how you have to go into it, because you have to go directly into the the core of the nucleus, which is the most important click in the whole scenario.
So let's.
Is dioptric?
Yes, ma'am.
This case is like in brown cataract that can help, but in black you are unable to see. And I don't think the trypanbul would help in these patients with cataract. Trypanbul would not help, I suppose.
What will not help?
Oh, in black
trypanblu, he's
saying. Is saying in black cataract perhaps it will not help. In brown, you may be still able to see the edge of the bluish rexes.
The function of doing trypanblu staining is there are two functions for that. First, at times the red reflex is decreased. Number one, when you are chopping, at times the chopper is, very sharp. You don't want to hit the anterior capsular rim and have an extension into the periphery. So that acts, you can watch it, you can stain it, and you can know that where is the edge, and you can keep away from the edge while you're chopping. So the function is not single. There are two functions of staining the anterior capsule.
And also the nature of the capsule itself becomes different. From elastic, it becomes a little more papery. Then again, one has to have caution, because sometimes if the zonules are weak, everything will go at the back. and then you will have a blue glow instead of a red glow. Then sometimes it becomes like,
Cleaning technique also, you have to use the minimal amount of, trypan view for that matter. The 30 gauge modified technique, which I gave, uses, there is only 1 or 2 drops of trypan view which is added, and that suffices. Because if we use more, then also the red reflex gets meshed up.
What I would do is just put an air bubble and put trypan blue underneath that. There's a uniform staining of the anterior capsule.
Absolutely.
Don't keep the trypan blue for long time. If you keep the trypan long time, it will penetrate into the posterior capsule, into the anterior vitreous as well.
Yes. Very good points. Would you introduce the next speaker?
Yes. Is Dr. Deepti there?
Dr. Shakeen, your talk was good. Thank you.
Very nice.
Thank you, ma'am. Thank you.
Okay. So our next speaker is a young and brilliant surgeon, Dr. Deepti Mehta, who after a very accomplished educational career, she is heading the Department of Cornea and Refractive Surgery at Kartik Netralaya, Bangalore. And she has a brilliant learning pearl for us today to share. Dr. Deepti, can you unmute yourself?
Yes, I'm just
Yeah.
sharing. So I thank ARC, Chitra ma'am, Dr. Harshal sir for this lovely opportunity. So today I'll just share a bunch of these 3 advanced cataracts and how we managed it using a technique of phacosection. So when we need to manage mature or advanced hard cataracts like these, we either can opt for a conventional SICS with the tunnel of 7 to 10 millimeters, or can mechanically emulsify the nucleus by phacoemulsification through a smaller tunnel. But today what we perform in these cases is the technique of phacosection, which is a good balance of both the techniques. It has the small incision and lower SIA advantage of the phacoemulsification and a manual machine-free phaco-energy-free advantage of the conventional SICS. So this is the 5.5 to 6 mm incision in a typical phacosection. So obviously to remove any nucleus through this incision, we need to fragment it. So today in this video, I would like to demonstrate different ways of performing the fragmentation in an advanced cataract. So let's speed up the tunnel making and rhexis. A bimanual prolapse of the nucleus exerts the least stress on the zonules, which could be already compromised in advanced cataracts. In the first method, we use an in-house made 26 gauge cannula. This is a diagrammatic representation of the cannula continuously injecting visco as it splits the nucleus, which is firmly supported by the wire vectors. The same technique in action here. So in this slow-mo video, the bleed actually allows us to visualize the outflow of viscoelastic that is continuously bathing the anterior chamber. In the next case, as the nucleus was a little harder, a 26 gauge cystitome is the same used for rhexis is used here. A few strokes are enough to split the hard core of any nuclei. Again, as we see in this recap, the air bubbles demonstrate how the cystitome is continuously injecting visco to coat the endothelium and also to maintain a safe space in between the nucleus and the endothelium. So in the third case, we use a snare. Snares are commercially available or can easily be made in-house by simple instrumentation. So first, the anterior chamber is deepened with a dispersive viscoelastic. The snare is horizontally inserted and slowly made vertical, thereby belting the nucleus. The snare is then firmly yet slowly pulled to split even the hardest of cataracts with quite an ease. So coming to the live video here. Ensure that each movement is very gentle and extremely conscious to avoid touching the endothelium or entangling the iris tissue. A cannula, again, which is continuously injecting visco, is used to feed the nucleus into the snare. So these bisected or trisected nuclei can be easily extracted through the 6 or sub 6 mm incision, again using a wire vectis and a cannula that is continuously injecting viscoelastic. A quick cortical cleanup and IOL insertion completes the surgery. So with this technique, we can achieve clear cornea on the next day, satisfying speculars at 1 month, and an average SI of just 0.5 diopters even in the hardest of cataracts, as there's absolutely no stretch of the incision. So one of these three techniques using simple instrumentation can be used to manage advanced cataract. The key factor in such surgeries is maintaining a deep anterior chamber, continuous viscoelastic, and maintaining a conscious distance between the endothelium and the nucleus, as most of the maneuvers are happening in the anterior chamber.
Lovely video, Dipti.
Yeah.
Very nice. Very nice video.
Very nice. I just wanted to ask you, like, I've seen your videos and plenty of your dads. In SICS, you need to create a little larger rexes. So how were you able to do your premium IOLs in these cases? Because we would not get that kind of a rexes wrap around the optic of the IOL. So how do you all get to optimize your results?
So basically, because we use the bimanual technique of prolapse, we really don't require a very big one. So here, as we saw, probably it was 6 or 6.5 if it's, because mature cataracts do have a little smaller nucleus. So I think that has never been an issue. Mostly you'll have to make sure the rexus is central. You have a uniform rim throughout, and that has never been an issue, ma'am. We have been doing even trifocal torics with this technique. So rather than the size, I think how we prolapse the technique of using the visco cannula and the dialer, we can easily pull it down to probably a 6 mm rexus. So only when you do it with a single hand, probably you'd require a larger rexus. So that has not been an issue at all.
Would you use this?
My loop.
Not use it, sir. We have not used it.
Not using it.
But would you use the same technique for all grades of cataract, or would you differ?
No. Yeah, usually if it's a softer one, the cannula is good enough. We use the cystitome and the snare only in harder cataracts. So otherwise, majority of the cases, it's just the cannula, which it can be the 25 or 26 gauge, which is used.
Would you have any tip for the beginners?
Yeah, I think to begin with, when I started, this was the technique I started off because I watched Dr. Ravindra do this. So I think it's only the manipulation of using both your hands in the anterior chamber. So probably in the beginning stages, we can have the entire nucleus come out and practice the wire vectors and dissection outside. So I think basically the coordination of your right hand when you're actually injecting visco and splitting, that may require a little few times of wet lab training, but otherwise it's pretty smooth once you have learned that, and consciously maintain the space between the endothelium and the nucleus. So conscious effort to keep the cannula a little down. So I think splitting outside will be a good way to begin with.
Yeah, ask a question, Dr. Chitra.
Yeah, yes.
Dr. Deepti, the videos are fantastic, and I only wanted to ask you whether you would differentiate between a clear corneal and a scleral incision depending on the grade of cataract and the size of nucleus. Like because when you're doing premium IOLs, if you would you change it, or would you always go with one of the two techniques?
So earlier it used to be close to limbal scleral incision. Now we have switched on to the posterior limbal incision. Certainly not a full clear corneal incision, but just posterior limbal incision without cutting open the conjunctiva. So that has been giving us excellent results as well. So probably to begin with, the scleral would be good, and we can switch over to the posterior limbal from there.
And how do you prepare this snare, Dr. Deepti?
So I think there is this video probably I can share in the group. I think Dr. Anil Shah's video on the YouTube. So basically it is a 36 gauge stainless steel wire, and there are two needles which are around 20 gauge. So I think probably the video can be shared in the group.
Okay.
So you insert the wire into one needle, you cut off the tip of the needle, insert the wire into one needle, and then put it through another needle and just press the second needle down there so that the wire is in place.
So you are giving a complete to the MyLoop people. They are making MyLoop and they are pricing it so high.
Yeah.
This is very simple, man. Very simple, very easy to use.
They have been using for years, no? Even Dr. Devashi's also made this snare, and a lot of people are using this snare.
So I'll go on to our next speaker. Dipti, that was amazing.
Amazing.
Go on to our next speaker.
Fantastic.
Our next speaker is Dr. Atul Khadane past president of Amravati District Ophthalmic Society, zonal member MERS, an innovative surgeon who is going to be showcasing an exemplary surgery in the next 4 minutes. On to you, Dr. Atul.
Hello, am I audible?
You're audible, but we can't see your video.
No, I think he has to play it. Yeah.
Is it? Huh, yeah.
It is
Yes.
perfect.
Good afternoon, everyone. At the beginning, I would like to express my thanks to Chitra ma'am, Harshul sir for giving me this opportunity. As you can see, this is a case of a traumatic subluxated cataract, almost 180 degree. I'm marking the subluxation with the area of center of the subluxation. Managing such subluxated cataract is always a surgical challenge. In this video, I'm going to demonstrate the use of AC anchor, a novel device to manage such type of cataracts. The most critical step in managing such cases to have a perfect CCC, irrespective of whichever method you use to fix the bag. After making a clear corneal incision, now you are seeing that I am inserting a tenoprolene suture 1.5 millimeter away from the center of my subluxation, passing through sclera and bring it out through the main incision with the help of a cannula. Routinely, surgeons use Sionis ring to manage such type of subluxation that is more than 6 o'clock hours or 180 degree. And in this case, I have used an implant called AC anchor. The AC anchor is a 2.5 millimeter wide PMMA uniplanar implant. It has a central rod and the 2 lateral arms. Now, once the tenoprolene suture needle is out, I'm threading it through the central hole of the central rod. And then the tenoprolene needle is again taken back through the sclera at the same site with the help of a 26 number needle. The 2 lateral arms of the implant are designed to reach the lens equator and provides a segmental equatorial support. And the anterior rod is sutured to the scleral wall using a non-absorbable suture, like in this case, a tenoprolene. So now you're saying that I have inserted the 26 gauge needle, and now I'm trying to threaded the tenoprolene needle into the hub of a 26 number needle. Now, once it is threaded into the hub of a 26 gauge needle, the tenoprolene suture is taken out. The uniplanar design of this implant allows a smooth insertion through a tight corneal incision. You don't have to enlarge the incision. However, the placement of the 2 arms, that is the 2 lateral arms behind the capsule and the central element in front requires some intraocular manipulations. Some surgical skill is required here. That is what I feel, because I face a lot of problems initially because of the uniplanar design. We can take the use of an 20 gauge forceps, 20 gauge side port forceps to facilitate this maneuver easily. Now, once this is done, the implant is fixed with an temporary stay knot. Don't try to fix the knot permanently here. Now, once the stay knot is given, the rest of the procedure is just like a routine cataract. The phacoemulsification procedure is to remove cataract is almost like as if we are doing on a stable and a well-centered lens. The biggest advantage of SA anchor is that here we can fix the bag before the removal of cataract. While the Sionis ring insertion before cataract removal is more challenging, not that easy. Rotation of a ring inside a bag which is unstable, there are chances that you may shear out the remaining intact zonals and more iatrogenic damage. The final suture knot is then tied in a 4:3:1 fashion, and it is buried in the sclera under the conjunctiva. Dr. Ehudasi, who is the inventor of this implant, he didn't recommend to bury the suture to make an scleral flaps for this. He said you can bury it directly under the conjunctiva into the sclera. Removal of cortex is in routine fashion with the bimanuals. I am routinely doing it, or whichever method you are comfortable. And putting an IOL in the bag is also in the same fashion. Nothing great in that. The suture, once it is done, the suture threads are cut flush to the knot. The wound is we can seal with the routine hydration, and thus we can see that the ASI anchor facilitates the creation of a well centered IOL capsular bag complex, and therefore it helps in effective visual restoration post-operative. Patient is very happy.
Thank you. Thank you, Dr. Atul. That was a, you stop sharing?
Yeah.
That was a wonderful video. I noticed that you placed this before you are even doing a hydro.
Yes.
Could it trap the cortex and epinucleus?
No, madam. If that is the trick. If I have done the first case, this is my fourth case. In the first case, where I initially do hydrodissection. After that, the cortical material once get disturbed, now it's very difficult to place the two lateral arms behind the capsule and the central rod in front of the capsule. The things get little bit blurred. In the second and third case, I thought I will put it initially because the things were very clear to do the procedure easily there. In the first case, I get a problem because I did hydrodissection first. The cortex get disturbed, and then it is just a mess to put the implant in the proper place.
So the other question which I wanted to ask
The knot is also exposed. Chitra, the knot is also exposed. So
I actually when I saw Dr. Ehudasi's video, and when I have this case, these Hanita peoples made a con call to Dr. AC, and he said that, and I also asked the same question: okay, do I need to make a scleral flaps to bury the knot? He said nothing to doing. I am doing this. I have experience of 25 cases, and I'm not doing any scleral flaps to bury the knot. So that's why I also
you just make a scleral groove there. You don't have to make a flap. Just put a groove there and put the knot in the groove.
Okay.
So that makes life easier.
Just like Hoffman's pocket.
Yeah.
Hoffman's you can do that.
Now, can you do this in the presence of a CTR or
Yeah.
PCR also? PCR.
Yes, that is the greatest advantage, because here the ASI anchor fixes the anterior capsular wall. The equator is still free. You can easily mix. I have used CTR with the with ASI anchor also. If I feel
not CTR, I meant if you have a posterior capsular rent.
In that case,
you have to take it out if you have, like, if you have a PCR, which happened after you have placed it. This would remain anchored.
Yeah, you wouldn't have to take this out, I guess, because this will be still anchored. Unlike a CTR, which you'll have to take out because that will get displaced.
Yes.
In fact, this might be the only because otherwise the CTS is always going to be better because it anchors at the equator and this anchors at the edge of the rhexis. So in a PCR, the edge of the rhexis, if the rhexis is still intact, would still be anchored nicely. So in the case of a PCR, this would be the ideal way to fixate rather than use a a CTS or even a Sionis ring.
Yeah.
I want to add a point. If you want to add an anchor before doing a hydro, what it said is that you put a viscoelastic just below the rhexis till the fornix. That actually pushes the cortex down. It creates your space, and then you put your anchor. So there is no question of your cortex getting engaged in this anchor at all. So this is one way of doing that.
No, the problem is sometimes the cortex will come and obscure your view. That is what he was mentioning, that when you do hydro, a lot of cortex will come there and obscure. You do not know whether it's going underneath the rhexis or above the rhexis.
So more the trick is, once you do your rhexis, put your viscoelastic from the margin of the rhexis.
Got your point.
And just keep putting it little all around till the fornix. Nothing is going to happen to your cortex. Create your space, and that's one way of even putting an endocapsular ring before. So this is one way that you'll never engage your cortex at all.
Yes.
And what is the
CTR, I think.
Yes.
And removal of the cortex in the presence of a CTR is not a big issue, because if you go circumferentially instead of radially, don't pull it towards the center of the pupil. Go circumferentially along the equator, then it will come out easily.
Yes.
So and what is the cost of this device, Dr. Atul? What is the cost of this device?
They are giving it 9,000. Hanita peoples are giving.
And do you reuse it?
No, sir. Once it is fixed, it is.
Oh, fine. I'm sorry. I'm sorry.
Unless the patient dies.
I'm sorry.
Patient dies, if a post-mortem we can take.
The advantage I feel is, sir, because the bags is fixed before the cataract procedure, na? So otherwise, if you use a Sionis or if you use a segment, you have to fix the bag with the capsular hooks, then remove the cataract, and then you have to put your the element to fix the bag. So doing an phaco in a bag which is not fixed, which is not that stable, little bit more chances of complications. Luckily, in all 4 cases, I don't have any sort of complication like PCR, madam said. So I don't have that experience. Also, what happens if the PCR runs? What should I do for the implant?
Perfect. So let's move on to the.
Go on to our last speaker.
Yes. So Dr. Suresh Pandey is our last speaker, and Dr. Suresh Pandey is the editor general of Rajasthan Ophthalmic Society. He's trained from PGI Chandigarh. He has done fellowship from US under Dr. David Apple, and he has numerous international publications, and is currently the director of Suvi Eye Institute and LASIK Center at Kota, a brilliant surgeon. Dr. Suresh Pandey, over to you.
Thank you, Dr. Harshul and Dr. Chitra ma'am, for making part of this excellent ARC webinar. Today, I'm going to share an important technique which is already published by some of the panelists, Dr. Rohit Om Prakash in the JCRS 2017 issue. And this technique is the pre-IOL implantation, pre-phaco implantation, or IOL scope folding technique in case of mature, hypermature, and Morgaginian cataract. As we all know that after lockdown, we are seeing a lot of cases like this, mature, hypermature calcified cataract with a lot of intralenticular fluid. And once you get such cases, it's very difficult to manage such cases. And there are a lot of high risk of complications such as Argentinian flex sign and floppy posterior capsule, weak jonules, etc. So the pre-phaco IOL implantation or IOL scaffolding technique in cases of intact posterior capsule can one of the most important tool to manage such cases. In this case, you can see the protrusion of the nucleus from the capsular bag after achieving capsular axis. And once you protrude the capsular bag, nucleus from the bag, make sure that you fill the capsular bag with the viscoelastic so that the capsular bag is fairly distended. Viscoelastic will act as a third hand, and this is the multifocal IOL implantation done in the capsular bag gently. And once the lens is implanted in the capsular bag, then we just manage the phacoemulsification of the hard cataract in the iris plane or somewhat in the anterior chamber plane. And it's very important to coat the endothelium by using viscoelastic such as chondroitin sulfate OVD to minimize the endothelial cell loss. And here, make sure that you remain gentle and to avoid the damage to the IOL. And here you can see the well-centered multifocal IOL in a case of hypermature calcified cataract, and the patient achieved excellent vision. This is the second case, hypermature cataract with the lot of cortical milk. So anterior capsule staining is very important tool in such cases, and I always prefer to stain the anterior capsule under an air bubble. You can use the ultimate soft cell technique described by Arsenov, and this is the phacoraxis or panchoraxis, what is labeled by Dr. Mohan Rajan. And in you can try phacoraxis, or you can use japtoraxis, and make sure that you aspirate the cortical milk. It's very important to aspirate the cortical milk to ensure the good visibility of the capsule flap. And we always try to aim for the 5 mm axis. And here once again we are just trying to protrude tilt the nucleus, and then you just implant the one-piece lens into the capsular bag after distension of the capsular bag using viscoelastic. And once the capsular bag is, once the lens is implanted, you can use the sharp chopper, or you can use blunt chopper. I'm using Dr. Mohan Rajan's sharp chopper to do vertical chop in this case. And notice that the cataract is removed nicely without much complication and much phaco power. And it's very important to use or to coat the endothelium with the chondroitin sulfate-based viscoelastic to ensure there should be minimal endothelial cell loss. And always avoid this technique in the shallow anterior chamber or nanophthalmos or small anterior chamber, small axial length cases. So make sure that you do endothelial cell count, and always avoid in cases of small eyes or shallow anterior chamber. This technique, AIOS scaffold assisted phaco, can be very helpful technique to manage the white mature Morgaginian hypermature cataract, especially which are not uncommon during post-COVID lockdown time. Thank you.
Thank you. Thank you very much, Dr. Suresh. Very valuable input you gave. I just wanted to know that would you always suggest placing the haptic of the AIOS scaffold on iris, or if you can visualize, you would put it in the sulcus?
Ma'am, in this case, in both cases, I put the haptics in the capsular bag. In both cases,
it was in the bag only. I think.
Yeah, it was in the bag.
You have to put it on the iris only if you have a PCR in place, where your
Yes.
IOS stability is
Yes.
Once you put it, once there is a scaffold there and you are collapsing the nucleus out, do you think you will cause a little more endothelial damage as compared to the phaco that you would do absolutely in the back?
Actually, once you put the lens in the capsular bag, you know, the nucleus is little away, it's in the iris plane, so there can be a little more trauma to the endothelium, but you can overcome this trauma by frequent coating of the endothelium with the viscoelastic such as chondroitin sulfate based OVD.
I have two questions for you, Suresh.
Sure.
One is this hard brown cataract, as Amrita said, you are bringing it anteriorly, iris plane, and sometimes you're closer to the endothelium than what you are normally. Second thing is the phaco energy. What is this thing that phaco energy cannot damage the IOL?
IOL, exactly. Yeah,
Yes, yeah, this is very.
IOL, you don't know what micro damage is occurring to those.
Yes, that's very valid question.
Lens, no?
That's very valid question, Dr. Mohan. First of all, I'm using your sharp chopper, Dr. Mohan Rajan sharp chopper. You can, you know, even kill the any patient, you know, with the sharp chopper. Yeah. and you know, you can emulsify any dense cataract. You know, it's very easy once you have your chopper in hand. And
drop nucleus lens also, no?
Yeah, yes. Concerning the damage to the IOL, you know, rings, multifocal IOL rings, this is valid concern. But what we can do, you can just be careful and use viscoelastic cushion. Use dispersive viscoelastic as a bolus, and that bolus will work as a, you know, some sort of coat the protect the IOL.
Actually, I think in defense of Dr. Suresh, I'm just saying that, you know, usually there is Morgaginian cataracts where the nucleus is really small. It may be hard, but it's really small. But definitely, if there's a shallow chamber and a thick nucleus, then it's not a great idea because the space will be very little and endothelial compromise will be much more. Yes. But I think if you reserve it for these small nuclei which are going to run around and, you know, be mobile, and there's almost no cortical support for the capsule, it's a great technique, and I think even I've used it a couple of cases.
Yeah. I think basically this technique which I published in JCRS was basically for the last nuclear fragments, because, you know, in Morgaginian cataracts there are 3-4 things which are happening. Yes, first, you are using high fluidics. And the second, there is some bit of capsular weakness. The vitreous at that point of time is at times fluidic, so there is fluttering. To prevent that fluttering, you can put the lens. But you know, the problem which we usually face in these Morgaginian cataracts is that we have difficulty in immobilizing the nucleus because the nucleus is mobile. In that situation, what you can do is you can immobilize it by taking the equatorial support of the opposite side. So you push it slightly, you have the equatorial support, and then you chop it. And once you have the last nuclear piece left, you can do. The advantage of using this scaffold is that you can work at a deeper plane and with the visco around. But definitely I have some reservations if we have to use it as a full, the whole nucleus piece coming, the whole nucleus coming up, and and the shallow chamber, as Dr. Gaurav said. So you can immobilize it, divide it, and last nuclear pieces you can use it.
That's very good point, Dr. Rohit. I think I had read your beautiful paper in the Jan 2017 JCRS issue. And in this case, which I have shown, I have used because this was a myopic eye, 26.18 millimeter axial length, and deep entry chamber, and the IOL power I put was for 12 diopter.
Perfect. Yeah.
Thank you.
Fine.
Any other questions, Harshul?
Yeah. Yeah, I think we are well in time.
Yes.
We have 10 minutes for discussion. If there are any other questions, we can take those questions.
What I would suggest for Morgarian cataracts, no? Can I?
Sure.
Morgarian cataracts, what you do is go bevel down, go to the center of the nucleus. Okay, it is called phaco boring technique, where you can go center, bore it nicely, and then you can chop from the periphery. That is because these cataracts are very, very small. That is, nucleus is very small. The overall diameter is very small. Go to the center and catch it nicely, and then use a sharp chopper, and then you can chop it easily from the periphery.
Yeah.
Only thing is, bringing it to the anterior chamber, I'm a little skeptical about it.
So in fact, you don't need a sharp chopper because posterior capsule is very much open there and exposed there. You just need a chopper to get it from equator of the lens. It cracks it easily. Yeah.
Dr. Rohit Prakash's technique works very well, where he takes the support of the equator and to stabilize the nucleus and then crack it, because otherwise all the other techniques will either bring it up or you'll have a sharp chopper which can damage the PC. So I think what Dr. Rohit explained and what he's published is fantastic.
Yes.
Do we have anything else, or shall we conclude?
I was wondering about that Pancho Rexis, and it's very scary for me. And it's very uncontrolled, frankly. Dr. Mohan said beautifully, but everybody else, I think the Pancho Rexis.
No.
I think
for a learning curve, you have to do it properly.
You don't want to learn.
HPMC, don't use Hyalon, don't use Viscoat. Go bevel down, go vertically down, and go all the way down on your phaco foot switch. One burst of phaco. If you go halfway through, then you will end up in an Argentina fact sign.
No Kelman tip. That is another important.
No Kelman tip. And straight tip, either 0 degree or a 15 degree.
No ozzle for that.
No ozzle. Straight longitudinal phaco, straight continuous phaco power. Keep it around 50% and keep the vacuum around 350. I usually use the Stellar machine for that. Whatever machine you're comfortable, yeah, that's fine. Just one punch.
Do you always get a round punch in the anterior capsule with this, or the edges are
regular? Get round punch, but you get something like this, like a pure.
Yeah.
But after that, you can make it 5, 6, whatever size you want. 200% it will not go to the periphery.
So I think I'm going to conclude now. Before our speakers leave, I need to thank them. It's been a truly amazing couple of hours with so many tips and learning in cataract surgery. I think it's not just for the speakers, it's been for every one of us. And my very special thanks, or rather our special thanks from ARC to our ever strong expert panel. Very impressive set of speakers who took so much interest in giving something new and novel in this webinar. Thank you, everybody. Our thanks, of course, are due to the AIOS admin team under Mr. Kripal, who have been very helpful at all times. Our webinar admin, Mr. Sunil, who's also been always a constant support and help. Sai and Manjula from Numerotech. Please do wait on speakers. You would get your link so that you could hear how well you spoke to us today. Our dear sponsors from Entode Pharma, who have been our great support for every venture of ARC. And our thanks are due to all the attendees who have been with us. And that itself is a huge source of encouragement. Thank you, one and all of you. So
Thank you.
Thank you very much, Chitra.
I read you all a little before time so that you could spend a comfortable Sunday.
Thanks for small.
Thank you all.
Great
Thank
meeting.
you.
Thank you, everybody.
Thank you,
Thank you,
everybody.
everybody, for
Thanks.
amazing presentation.
Thank you. Thank you.
Thank you.
Thank you, everybody.
Thank
Thank
you,
you.
everyone.
Thank you, Chitra
Thank
ma'am.
you.
Thank you,
Thank you very
Mohan.
much.
Thank you all.
All the best.